a group picture. With that, we would like to also move to our next session. Can I request our chairpersons to please join us? We have Dr. Basab Mukherjee Sir, Dr. Abharani Sinha, Dr. Geeta Sinha, and Dr. Himali Sinha to please join us. Can I also request our speaker, Dr. Pushpa Chaudhary ma'am, to please join us on the dais. The good part is I'm a little relaxed for this session because we have Dr. Basab Mukherjee as a chairperson, and I'm sure he's going to help me to keep this session on time as well. And he's smiling when I say that. Thank you. Can I request Dr. Basab sir to join us as a chairperson? Thank you, ma'am. Thank you, Dr. Sethu sir. Everybody look. 3, 2, 1. Thank you. Thank you, ma'am. Thank you. Dr. Basab. Yes, ma'am. Dr. Pushpa Chaudhary ma'am, to please be on the dais. With the permissions of the chairperson, we have Dr. Pushpa Chaudhary ma'am.
Yeah. Thank you, Nikhil. So this is a session of WHO. It's a plenary session on improving maternal and newborn health. We don't need to introduce WHO to us. WHO is something which we've heard before we became doctors, and WHO is something which we keep on hearing, the pandemic, all the work that they've done, and WHO India is here. Dr. Pushpa Chaudhary is a very strong partner of Foxy for many years, and WHO India, she leads this now here. And today we want to hear from her on SDGs and maternal health. May I request the audience to kindly remain silent and keep your phones in the vibration and switched off mode, please. We want to hear our speaker, Dr. Pushpa Chaudhary, on SDGs and maternal health.
Thank you so much, sir. Respected chairpersons, distinguished colleagues and delegates, warm greetings to all of you on behalf of WHO India. And this is indeed a pleasure for me to be here in this gathering because I'm so close to this city, Patna, where I spent 14 years from my intermediate to MS, 14 years, not Banvas, but Siksha was. So whatever I am today, the foundation was laid here very much. So I'm just going to give an overview because we can talk on SDG whole day, it will not finish. So SDG overall, and what is SDG target for maternal health, and what countries, how it's monitoring and what we have achieved so far. So this is basically a framework for a global development agenda, and it's a blueprint for peace and perspective for people and the planet, now and into the future. So it's all peace, peace, people, planet, partnership. From 2015 to 2030, and the plan of action is based on what we learned and what was left behind from MDGs. So there are 17 goals, 169 targets, and 232 indicators for countries to monitor. It's very ambitious, and it's not focused on one individual's right to health, right to entitlements, right to equality, but it talks about as a whole planet perspective, peace and partnership, and the key focus is on inequality reduction among countries and within countries, and it's all built with the focus on collaborative partnership. So you can see 17 goals, and basically these are all interlinked, integrated, and they balance the 3 dimensions of development: the social, economic, and environmental. So goal 1, no one should be poor, no poverty; 2, zero hunger; 3, good health and well-being, which we all are very much concerned as a key stakeholder; quality education, goal 4; Goal 5, gender equality. Goal 6, clean water and sanitation. Goal 7 is affordable and clean energy. 8, decent work and economic growth. 9 is industry, innovation and infrastructure. 10 is reduce inequalities. 11 is sustainable and sustainable cities and communities, the smart cities concept. 12 is responsible consumption and production. 13 is climate action. 14 is life below water. 15 is life on land. 16, peace, justice, and strong institution. And 17 is the key, is the partnership at all levels. So these are very much interlinked and overlap each other. So development cannot be just one agenda in isolation. It's a collective effort in all sectors. So in this slide, basically, I also want to highlight this SDG 3. It reminds us our ancient, agenda. Very much we know, Sarve Santu Niramaya, which has been the Indian social goal from very beginning, So in this 3 columns, the first one is basically all these targets are based on those that was from MDGs, the unfinished agenda, like reduce maternal mortality and preventable newborn and child deaths, ending epidemics of TB, HIV, AIDS, malaria and NTDs, ensure universal access to SRH. So these are the ongoing agenda. But in SDG, we have added new SDG targets like NCD, substance abuse, road traffic accidents, and reduce deaths from hazardous chemicals and air pollution, soil pollution, and extras. And this third column is basically how to achieve, what are the means of implementation these targets. So we talk about framework, Convention on Tobacco Control for reducing NCDs, access to medicine and vaccines for all, research and development for medicines and vaccines, health financing, health workforce, and strengthen capacity for early warning, risk reduction, and health risks, so health emergencies. So these are the overall concept of what is SDG Goal 3 and what are its targets. So this slide basically shows, how health-related goal is linked with other SDG goals. Health agenda cannot be moved forward in isolation. So you can see ending poverty, Goal 1, clean water and sanitation, Goal 6, Goal 5, gender equality, Goal 2, zero hunger, nutrition, and Goal 16, peace. So, if you talk of partnership, we cannot do anything unless we go for collaboration and effort engaging all stakeholders. So this is very much interlinked. So coming back to on maternal health, so SDG Goal 3 and 3.1 talks about by 2030, reduce the global MR less than 70 per 100,000 live births. And it should not be more than 140 for any country. And there are 2 indicators for monitoring this target, maternal mortality ratio and proportion of births attended by skilled health personnel. So there are 2 guiding documents to help countries how to accelerate SDG 3.1. The first one is the Global Strategy for Women's, Children, Adolescent Health, which talks about survive, thrive, and transform. So just reducing deaths is not enough. We have to ensure that there is health and well-being and enabling environment so that any individual who is born develops into full potential. So this is a broader agenda. And the other one is ending preventable maternal mortality, EPMM 2015, which talks about renewed focus on improving maternal, newborn, and health being. So these are the 2 documents. And the EPMM strategy is very much focused on, what should be the targets for at country level, at subnational level, at global level. So for India, what should be the targets for, ANC, so coverage of ANC at India level, at state level, and at district level. Similarly, targets for stillbirths, postnatal care, access to emergency obstetric care within 2 hours. So it talks about what percentage of the countries should have at least, like 60% should have access to EMOC within 2 hours. And last one is a legal and policy environment to ensure right to SRS. So these are actually global documents, and country adopts these documents and try to align their policies and programs as per the documents. So this helps the country how to make that journey to reach SDG goal 3.1. So when you look at what is status in India, there are some milestones, like in 2017, Global SDG Indicator Framework was adopted in UN Assembly, and in 2018, Indian Cabinet approved the National Indicator Framework for monitoring SDGs. In 2018 and 19, NITI Aayog helped all states to develop their SDG vision documents, and NITI Aayog is basically overseeing the SDG implementation. Ministry also developed National Monitoring Framework in Health SDG, and disaggregated into 4 thematic areas like RMCH, communicable disease, non-communicable disease, and health systems. Ministry of Statistics and Program Implementation updates national framework and releases SDG progress reports. And each country, they can have voluntary national review, and they present at UN level. Last one was done in 2020 by India. So if you look at the maternal mortality ratio reduction at country level, so India has reduced what was almost 400 plus to 97, according to SRS publication last time. And similarly, Bihar has also shown a remarkable improvement from 531 to 1118. Similarly, birth attended by skilled health personnel, there is significant improvement from what was 34% to almost 90% at India. Bihar from 20% to 78.9%. So Bihar is also making progress, though we have to work more. And these are the programs, I am sure you are all aware, these are the programs that really help India to improve their indicators for maternal health. I'm not going into detail due to time constraint. To summarize, India is committed to achieve maternal health targets as laid down SDG 3, and the states have the primary responsibility for monitoring and review state level, district level, even at local government level, with regard to what is progress is being made and what are the bottlenecks and how to improve their targets. And most crucial thing is measurement. We say in public health, if you don't measure, that means you have not done anything. So generating timely and reliable data on maternal mortality, maternal death review surveillance. This is a program WHO India has supported ministry in developing a software dashboard where the ministry directly gets real-time data every day from states. So this is something where, as we obstetrician, should be very much engaged and should be very much demonstrate our leadership here, because all these data and the findings helps us to renew our planning and strategies for improving health outcomes. And capacity building is another area which is very much important. And ultimately, the whole is the collective journey of all stakeholders. Government could be in the driving seat, but they have to be complemented by non-government sector, other state agency, private sectors, civil societies, and the professionals and professional organization to join hands and ensure that there's universal maternal health coverage and no one is left behind. So I will end here with a great thank you, and I would also reiterate that obstetricians should demonstrate leadership to improve maternal health outcomes, and you must have a public health vision to understand the wide scenarios. Thank you very much. Once again, thank you for giving me this opportunity.
Thank you, Dr. Pushpa. That was a wonderful presentation. And you're right that the program is very ambitious and each one should chip their bit in to make it a success. And as obstetricians, I think a lot of weight lies on our shoulders. And yes, health cannot be developed in isolation. We require to look at all the other things. Thank you once again.
Thank you.
Thank you, Dr.
Now it's time to invite our next speaker. She is none other than the chairperson of Labourcon 2023, the Vice President Foxy from East Zone, the pride of Bihar, Dr. Alka Pandey.
Thank you so much.
And she has been the chairperson of Practical Obstetric Committee and also the past president of Patna OBG Society. And she is going to talk on Labour Care Guide. So over to you, Alka Di.
Thank you so much. Esteemed chairpersons and the August gathering in the hall. My topic is Labour Care Guide by WHO. So majority of maternal and perinatal morbidity and mortality are caused due to complications during labor and childbirth, and these are largely preventable through timely intervention. Improving the quality of care around the time of birth is the most impactful strategy for reducing maternal and perinatal deaths. So, modern management of labor focuses on attainment of safe motherhood, positive childbirth experience for the women undergoing labor, healthy mother and healthy child. So, WHO recommendations on intrapartum care for a positive childbirth experience are the use of effective labor and childbirth practices, avoidance of ineffective practices, support women to achieve their desired physical, emotional and psychological outcomes for themselves, their babies and their families. So, the schematic representation of the WHO intrapartum care model includes respectful maternity care, effective communication, informed consent, emotional support and companionship, pain relief strategies, oral fluid and food intake, mobility in labor and adopting birth position of choice, regular labor monitoring, documentation of events, audit and feedback, and maintaining continuity of care in all healthy pregnant women. So, the latent phase of labor has again been redefined. The latent first phase is a period of time characterized by painful uterine contractions and variable changes of the cervix, including some degree of effacement and slower progression of dilatation up to 5 cm for first and subsequent labors. The standard duration of the latent first stage has not yet been established. During the latent phase, the admission may be delayed if the maternal and fetal status are reassuring, as the woman is still in the latent phase, which is up to 5 cm of cervical dilatation. Education and support, oral hydration, then positions of comfort and massage may prove to be beneficial, and many studies have revealed that delayed admission groups have lower rates of epidural use, augmentation of labor, and the patient had greater satisfaction and spent less time in labor and delivery unit. The active first stage is characterized by regular painful uterine contractions, a substantial degree of cervical effacement, and more rapid cervical dilatation from 5 cm until full dilatation for first and subsequent labors. However, the duration of active first stage from 5 cm until full cervical dilatation usually does not extend beyond 12 hours in first labors and usually does not extend beyond 10 hours in subsequent labors. So now talking about respectful maternity care, it is all about maintaining confidentiality and privacy, communication with dignity and respect, then ensuring freedom from harm and mistreatment, and enabling informed choice, consent and continuous support during labor and childbirth. And women's experiences with maternity caregivers can empower and comfort her or inflict lasting damage and emotional trauma. Now, there is a stress on birth companions. Birth companions provide emotional support and reduce the stress a pregnant woman undergoes during delivery. Emotional support helps in reducing adverse outcomes such as prolonged labor, use of analgesia, episiotomy, cesarean and postpartum depression. Then the birth companion can also identify danger signs early and inform the service provider. Then effective communication should be a part of our practice. Effective communication with the patient and attendant should be done regularly by the care provider, and continuity of care throughout the antenatal, internatal and postnatal period has proved to be beneficial. Now pain relief, we can do it by massage or application of warm packs, progressive muscle relaxation, deep breathing, music, then parenteral opioids such as fentanyl and pethidine, and lastly and most effective, epidural analgesia. Oral intake of moderate amount of clear fluid is recommended. Particulate containing fluids and solid foods should be avoided. Mobility is not restricted. There is little evidence that one position is better than the other. Supine position may cause supine hypotensive syndrome and more frequently fetal heart rate decelerations. Upright position shortens duration of first stage of labor, less likely to have cesarean section births, reduction in episiotomy, but more second degree tears and PPH. Now, what are the practices which we had practiced and they need to be avoided? Routine clinical pelvimetry, routine cardiotocography on labor admission, routine perineal and pubic shaving prior to admission, then administration of enema, continuous cardiotocography in low risk patients, routine vaginal cleansing with chlorhexidine, and a package of care for active management of labor for prevention of delay in labor is not recommended. So the labor care guide has 7 sections. Section 1 is identifying information and labor characteristics at admission. Section 2 is supportive care. Section 3 is care of the baby. Then section 4 is care of the woman. Section 5 is labor progress. Section 6 is medication. And section 7 is shared decision making. So this is the labor graph which we have to fill. Now, care of the fetus. The well-being of the baby is monitored by regular observation of baseline fetal heart rate and decelerations in fetal heart rate, amniotic fluid, fetal position, molding of the fetal head and development of caput. Intermittent auscultation of FHR is recommended every 15 to 30 minutes in active first stage of labor and every 5 minutes in second stage of labor. Each auscultation should last for at least 1 minute during a uterine contraction and for at least 30 seconds thereafter. Fetal assessment is done every 30 minutes and baseline heart rate, type of deceleration, color of liquor, fetal position, presence or absence of caput and molding is noted and compared with the alert parameters. The women's health and well-being are monitored on the LCG every 4 hours by regular observation of pulse, blood pressure, temperature and urine output. They are recorded and compared with alert parameters. Labor progress is recorded on the LCG by regular observation of the frequency and duration of contractions, cervical dilatation and descent of the baby's head. Number and duration of contraction should be monitored every 30 minutes in the first stage and every 5 minutes in the second stage. Any abnormal or alert finding needs to be verified for next 10 minutes and any alert parameter warrants action. After assessing maternal and fetal well-being, internal examination is done under aseptic technique to examine the cervix. In the active first stage of labor, X is plotted in the cell that matches the time and the cervical dilatation, and in the second stage of labor, P is used to indicate where pushing begins. Vaginal examination should be done every 4 hours, unless otherwise indicated. Now, descent is assessed abdominally, and 0 is plotted in the cell that matches the time and level of the descent. The head is divided into 5/5, 5 by 5, 4 by 5, 3 by 5, 2 by 5, 1 by 5 and 0 by 5 are used to describe the fetal station. It should be done before vaginal examination and is repeated 4 hourly. Based on the findings and after informing the women, plans should be made by shared decision making. In case of duration of active phase exceeding 12 hours, another labor care guide graph can be added. Now, all the medications which we give have to be recorded. Consistent recording of all types of medication used during labor, oxytocin and its dose, other medications and IV fluids. Continuous communication with the woman and her companion should be done, and consistent recording of all assessments and plans agreed. Birth is usually completed in first labors within 3 hours and in subsequent labors within 2 hours. High quality studies data support pushing at the start of second stage of labor for nulliparous women receiving epidural analgesia. Delayed pushing does not increase vaginal birth. On the contrary, risk of infection, hemorrhage and neonatal acidemia increases. Routine episiotomy is not indicated. Perineal massage, warm compresses, hands on guarding of the perineum are recommended, and head of the baby is delivered in between contractions. Now, active management of third stage of labor is recommended. Oxytocin 10 international unit intramuscular or oral misoprostol 600 microgram or carbetocin may be given IM or IV. Delayed umbilical cord clamping not earlier than 1 minute after birth. So it can be done up to 1 to 3 minutes. But if the baby is preterm or asphyxiated, you have to remove the baby as soon as possible. Controlled cord traction should be done only in the presence of skilled health care worker, and uterine massage also, sustained uterine massage is now not recommended. Neonates who start breathing on their own after birth, suctioning of the mouth or nose should not be performed. Skin to skin contact with their mother during the first hour of birth to prevent hypothermia and promote breastfeeding and increase bonding. Then 1 milligram of vitamin K intramuscular after the first hour of birth is recommended. Bathing should be delayed until 24 hours of birth. Mother and baby should stay in the same room 24 hours a day. Routine antibiotic prophylaxis is not recommended in normal labor and when episiotomy is done. Regular assessment of pulse, blood pressure, fundal height, uterine contraction and vaginal bleeding should be done, and urine void should be documented within 6 hours. To conclude, much has changed in how we provide evidence-based, respectful intrapartum care in the last 50 years, and we have a responsibility to provide the highest level of evidence-based care that respects the wishes of women. Practice guidelines should be followed so that mortality and morbidity levels decline and every woman has a positive childbirth experience. Thank you very much.
Thank you, Dr. Alka Pandey, a very dynamic and academic obstetrician and gynecologist. It is such a wonderful and comprehensive description of how we have moved from machines and needles towards tender, loving care and giving just personal care and being with the patient along with her choice companion. So there are a group of women in England I have seen in labor wards, like they prefer no needles, no investigations, no needles. They don't even get active management of first stage of labor done by that prick, one prick. So there is a school of thought who promotes that. But anyway, one has to be vigilant, but minimum of interference and maximum of tender loving care and observation. This is the guideline. And you have very beautifully described this management of labor. Thank you.
Thank you so much.
Okay, so thank you, Alka-di, for your wonderful talk. And now it's time to call upon Dr. Deepti Agarwal, who is again a WHO representative, I think a senior technical person from WHO, and she'll be talking on WHO postpartum guidelines. So over to you, Dr. Deepti. Please come on the stage. Her intro is there. She is in the WHO country office for India. She is a pediatrician and public health professional with 25 years of work experience across RMNA-CAH advocacy project, implementation and capacity building in South and Southeast Asia. She is an honorary fellow of the Indian Academy of Pediatrics in 2022. So over to you, Dr. Deepti.
Yeah, thank you, chairpersons, and good afternoon, everyone. So I will be talking a little bit about the new guidelines of WHO, which is about recommendations for maternal and newborn care in the postnatal period. And the postnatal period continues to be a very critical period for mothers and newborns in some settings. And what we just heard in the previous presentation was that we need to make a lot of investment in the intrapartum period, because that is where we get the maximum gains in terms of reducing maternal mortality. But I think the mortality in the postnatal period also continues to remain high. And up to 30% of maternal deaths are occurring in the postpartum period, and in India we have a neonatal mortality of 20, out of which the 15 newborns per 1,000 live births do not survive the first week of life, and within that first week also the first 2 days are most critical. And I think why it is important for the obstetricians also to be involved is that, you know, most mothers will be in your care in the first 24-48 hours in the facility where they have delivered. So I think it's time to also focus on the postnatal care. And the second issue, which I think Dr. Pushpa had also highlighted, that in the global strategy we are now talking of survive and thrive. And thrive relates to health and well-being, which ma'am you just mentioned, that you know how the focus is shifting not just into for medical management but overall health and well-being. So I think the postnatal period is a very important period where, you know, we can leverage this opportunity to improve the overall, you know, maternal well-being and support the nurturing care for newborns. And I will talk a little bit about nurturing care in the following slides. So when WHO brought out these guidelines, there are actually 63 recommendations, and they are related to maternal health, newborn health, as well as what we can do in the health systems. And I was really wondering, you know, how to present these 63 recommendations, because I think as gynecologists, obstetricians, you are already practicing, you know, many of those recommendations. They are part of your clinical protocols. And then, you know, when I was present in the cultural program yesterday, it gave me an idea. What I could see that, you know, the entire community here is so passionate about health, fitness and mental well-being. And I thought, let me just focus on those recommendations from WHO, and also to showcase that WHO is also shifting its recommendations towards a more positive experience for mothers and newborns, and talking about the health and well-being in a broader way than just the medical interventions. So while I think you already do the maternal physiological assessments and manage pain and constipation and breast engorgement and conditions like that, what are the other things to focus on? So the most important, I think, thing here is about screening for postpartum depression and anxiety. So globally, we have seen that depression and anxiety in the postpartum period is one of the leading causes of disability in women. And not only the women and the families affected, even it has a profound effect on the parent-child relationship and the ability of the mother to provide nurturing care and therefore, contribute to the development of the child. So universal screening for mental health is something that we should consider including as part of our clinical practice. And it can be done in a simple way. It could be self-administered when it is possible. We have educated women in your care. But if not, I think any worker can be trained to administer a simple questionnaire. And women who are identified at risk, and based on the screening, they must be offered psychological intervention or psychosocial support as is required. So this is one area which is coming up more and more, which is maternal mental health, which is going to be increasingly become the focus of our care. The second one, which I saw again, that all the obstetricians yesterday shared their videos where they were like physically active. So I think that is the new recommendation for the mothers also, and I thought it would resonate very well, not only with the obstetrician community, but also with the young mothers. The fact that they must remain, physically active. And I remember when, 20 years ago when I delivered, we had an absolutely sedentary postpartum period, just high calorie food and a lot of rest. So I think that has changed in a big way, that, all postpartum women must undertake regular physical activity, at least 150 minutes a week, which comes to around 20-25 minutes per day. And it can be cumulative over the day, doing routine household work, doing some leisure activities, walking. So basically, a lot of physical activity, and to limit the time spent being sedentary. I think that is one important, change that WHO is now recommending. So I think those were the two issues that I want to focus in the maternal health. When it comes to newborn health, again, I'm sure there's a pediatrician, or maybe you have other workers in part of your team who are doing regular newborn assessments. Here I would just like to focus on 2 or 3 new recommendations, and which can be undertaken, especially if you have a multidisciplinary team providing maternal and newborn care. So there is now a new focus on universal screening for newborns. So first we come to universal screening for abnormalities of the eye. So some of the common conditions are congenital cataract, retinopathy of prematurity, glaucoma. So blindness is one of the leading, causes of disability amongst children. And it is now recommended that if feasible, universal screening for eye abnormalities must be done in all newborns before discharge. So even if that is within 24 hours or within 48 hours, it should be done. And let me say, there are hospitals here in India and Sri Lanka who are already piloted it or already doing it. So it can either be done with a simple, simple torch test, or an ophthalmoscope can be used to do a red reflex, for which of course an ophthalmologist would be required. But the pregnancies are becoming precious, and I think the parents are willing to invest in screening, and I think you do a lot of screening pre-pregnancy in the antenatal period. So this is something that can be offered to the parents. The other is the universal screening for hearing impairment, and globally the incidence of permanent bilateral hearing loss is 1 to 1.5 newborns per 1,000 live births. So of course the incidence or the prevalence remains small, but what I have personally seen, that a lot of these infants are only diagnosed in the second year of life, and they have delays in language, when they are not able to speak, then you start looking at the cause and you find that the the child has bilateral hearing loss. So this is something again which one can invest in, and there are now more simpler equipment which is available. You don't need a audiometrist. It can any simple health worker in your team can be trained to do this test, and it may take around 5 minutes to 10 minutes, but what you need is a soundproof room. So this is again something which is being recommended. The third is the universal screening for neonatal hyperbilirubinemia. So we have been screening for jaundice by looking at the palms and soles and the color of the yellowness of the skin, but it has been shown that compared to clinical screening, using of transcutaneous bilirubimeter can reduce the incidence of infants or newborns who will come back to the health facility with severe hyperbilirubinemia. But I just want to say that it is very specific that a transcutaneous bilirubinometer must be used. There is no recommendation for taking a blood sample and doing total serum bilirubin. So there is no additional advantage when you doing that, but definitely using this transcutaneous bilirubinometer can reduce the overall proportion of children who come back with severe hyperbilirubinemia. The other important one is on the whole body massage. I think this is something we have always been debating, whether to give a massage or not to give a massage, what is good. But I think now there is a clear direction from WHO that whole body massage is good, although there is no recommendation for using an emollient, but it can be used if it facilitates the whole body massage, and it has been shown that it provides a lot of tactile stimulation, and it improves circulation, that we always knew, but it also soothes the peripheral and the central nervous system, increases vagal activity, which means that it reduces the cortisol and catecholamine levels and reduces the stress in children. Therefore, it can promote soothing behavior in infants. So that is some of the new evidence which has come for the whole body massage. A simple plant-based oil a little of it can be used to facilitate whole body massage. Again, we come to the Thrive agenda, which we say is now very important, and WHO has a lot of focus on nurturing care for newborns. And what it means is that we have to focus on the development of the brain of every baby, so that the child, when it grows up, is able to achieve their whole full potential. So I think a lot of recommendations have come out on how to put parents at the center of this nurturing care. And there are 4 recommendations. One is that all infants should receive responsive care, and what is responsive care is that when the parents are able to and caregivers are able to identify the newborn signals, such as when is the baby ready to feed, is the baby having pain or stress, and how to appropriately respond to those cues. That is one important thing. Second is the focus on positive caregiver-infant interaction. Also, a lot of focus on early learning opportunities. So I think we have been talking a lot now that the fetus starts learning in the womb. And in the last months of pregnancy and soon after birth, there are 1 million neuronal synapses which are being formed every month. So the brain is undergoing very quick, wiring. So input or that is given to the child that results in better synapses formation. So early learning opportunities is something that all mothers and caregivers should be informed about. And what is it? It just involves simple activities like making eye contact with the baby, smiling, talking to the baby, singing to the baby, and gentle touch, for example, just simple massage. So I think a lot of focus on nurturing care, and of course the last and important component here again is the maternal mental health, because without a mother who's able to care for the baby, there is going to be no nurturing care for the baby. So these are some of the new recommendations for growth and development. And the last one, which again I also like to speak even before these recommendations were out, was how to involve men in the postnatal care. So we have marginalized men, at least in public health system. I don't know how it works in a private practice, but in a public health system there is no infrastructure There are no policies which allow men to be part of, care for a mother during the entire process, her entire journey from the time of soon after pregnancy to the postpartum period. It is completely like supervised and taken care of by women. So although, we have to be mindful that the women should be able to make their own choices and should be able to make decisions themselves, but it is very important that men are involved at every stage, because I think that will promote the self-care for the women. It will help her breastfeed, help her get that supportive environment at home through which she can provide nurturing care for the mother, for the baby, and also be able to access skilled care throughout pregnancy and in the postpartum period. And of course, use of contraceptive anytime in the postpartum period. So I think how do we bring more men into the care of women is important. I know more men are giving care to women, as I saw a lot of male obstetricians here, but how do men get involved in care of their own family is equally important. So that's the WHO's vision for quality care for women and newborns, that every woman and newborn must receive quality care and have a positive postnatal experience. That is the end point for any woman giving birth and for her newborn. Thank you.
Thank you, Dr. Dipti. That was very informative for all of us. When we talk about postpartum care, we usually limit ourselves to anemia and family planning. But mental health, of course, as you rightly said, is something which we can do in our own clinical practice. And about the pediatrician does several things, some of it possibly what you've already mentioned, but transforming everything into a public health perspective is a challenge of itself. So definitely very informative, and thank you for your talk on this.
I would just like to take this opportunity to thank Dr. Pushpa Chaudhary. I think she is from Patna Medical College, and both myself, Geeta and Himali, we both had the opportunity, all of us had the opportunity to work with her, and she has supported this conference, so I really thank you. And both the talks were excellent. Dr. Dipti, I think she has spoken so well about the postnatal care, how to involve the parents, how to involve the male partner. I think these were two important points. So thank you so much for coming to Patna, for enlightening us. And now I take the opportunity to invite Dr. Poonam and Dr.
Well, Dr. Poonam Dikshit is a very renowned obstetrician and gynecologist in Patna. She's so academically inclined. She was a year junior to me, I think a year or two, and she always came to me for guidance. A very intelligent girl and a very, very good doctor. She is so strict about ethics, medical ethics, and proper patient management, and she is a wonderful orator. And I invite her to deliver her talk on surgical safety checklist for C-section, which is again very important. All of us are doing it, but checklist is very important. It has to be checked.
Thank you. At the outset, I thank the organizers, Alkadi and Abhadi, for giving me this opportunity. I'm sharing the platform in this WHO forum. And just, my talk is on checklist. So why do we, before I proceed, does anybody use checklists in obstetric practice in the audience? Raise your hand. Yes. And how many of you use a checklist when you're packing for a conference, which sari to wear, which jewelry to wear? I'm sure it will be more than 80%. So the checklists, they are very, very useful tools, don't take very long. It should not mean in your unit that, oh, another work. Most of the obstetric units, whether they are delivering 5 babies, 10 babies, they're overworked. Everybody just huffing and puffing in obstetric, even in the most disciplined obstetric units in Western world, you see this. So the checklists are there to make our life simpler. And why? Because we do complex tasks involving several steps, team members and variables. Things can vary, like a woman who is very, very low risk, suddenly her hemoglobin drops and she might be an abruption. Checklists are strategies to overcome failures, that is keeping in theme of WHO SDG goals and the theme of this very conference, Swasth Nari Sukhi Nari. And avoidable failures are common and persistent. We will all agree there are major barriers between what we know, what we hear in the conference, and what we implement in the clinical practice. There are many, many barriers, and the checklist bridge the gap. And they're very simple 2-minute solutions. And why did this WHO Safe Surgery checklist came? Because after pilot studies involving 8 hospitals globally, the checklist showed there was 36% decrease in complications and 40% decrease in number of deaths. This was in 2008. Many of you might remember that that was the year the surgical safety checklist was spread everywhere. It came in the media. And in this collaborative study, India also participated. St. Stephen's Hospital from Delhi was part of this collaborative study. Professor Atul Gawande, Professor of Public Health from Harvard, he was one of the leading investigators in this pilot study. And the New England Journal of Medicine in 2009 published these findings. This is an open access article, so do go to them. And since then, checklists have been adapted in many countries in various operations. Cesarean section is a very common procedure. Infection, hemorrhage, and anesthetic complications can occur. So our checklists are targeted to minimize these complications. Deep venous thrombosis and pulmonary embolism is less common but more catastrophic. And we all want to be safe, and use of checklists is a tool to help us achieve the goal. So this looks quite sort of, it's a busy slide, but if you go through, when do we check? Before anesthesia is given. So all of us check, is she the right patient? Believe me, wrong patients can be taken to theater in busy units. Is consent taken? And there's a lot of emphasis on, like the social aspect of the care. So has everybody introduced? And any high risk factor, has it been discussed with anesthetist? Is there a difficult airway? And is she at high risk of blood loss? We heard some excellent talks from Manju Gita Mishra and Dr. Shanti Roy. Does she have placenta previa? Does she have placenta accreta? And before we give skin incision, we check about antibiotic prophylaxis. We all give before skin incision is given in cesarean section. Then any anticipated critical events, like how long it is going to be, is she somebody with previous 3 cesarean? Very important in private setup, the anesthetists, they are tied up, they might have a call from another place. So we need to tell them this is a surgery which is going to take longer. And before patient leaves the operating room, a correct procedure should be documented. And a specimen labeling, this is the general note for cesarean. And the surgeon, anesthetist and nurse, they should alert what are the key concerns about the postpartum recovery. So you just speak aloud, identity, procedure and consent, category 1, 2, 3, 4 depending on the urgency. Is the anesthetic machine and medication check complete? Does the woman have a known allergy? Any difficult airway or aspiration risk? Are blood products available? If, how urgently they are needed and how long it will take? Has the appropriate recent antacid prophylaxis given? Is the resuscitator ready? Has the neonatal team been called? Before skin incision, just the introduction what I was talking about. What additional procedures are planned? Any critical or unusual steps you want the team to know about? Are there any concerns about the placental site? Is the placenta low? Any suspicion of accreta? So accordingly, our plan should be discussed before, and this should be spoken aloud with the team so everybody is aware. Time out before the skin incision. Check with anesthetist. Does she have any allergy? Does she have bronchial asthma? If she has BPH, we will not give her Corboprast. Are instruments sterile in very busy units? That's important. And any equipment concern. The paramedical staff checks, are cord blood samples needed? Is the catheter draining? And the third one, and most of us don't use it, so, but VTE prophylaxis is important. And sign out to be said aloud before she leaves the theater. Have we documented everything? Has it been confirmed that instrument swabs and sharp counts are correct? Have specimens been labeled, and record of blood loss is important because that is in the postpartum recovery. This is, I just got it from one of the NHS hospitals. I'll just omit this. And then, how do we plan checklists? Checklists will vary in different units, and the quality of paramedical staff you have, the workload you have. So broadly speaking, when you develop your guidelines, it should be very clear, concise, and objectives. Like if in particular unit, infection is a risk, then infection, how to control infection, give antibiotics 60 minutes before, the current evidence like manual removal of placenta is supposed to increase the incidence of endometritis, and swabbing also reduces. So your points can vary. So what WHO has given us only a guideline, and we can adapt to our unit. In my unit, we always check whether pediatrician is present before I give the incision. But I also check, has the pediatrician read the notes? Does he know about the growth scan? Does he know this baby is growth restricted? Because these are the very important steps which are often missed. And then have you considered adding items that will improve communication among team members? Communication is one of the major area where failures can lead to increased complications, and we should all try. When you will say, so speak, make sure that that person knows that yes, he has given the antibiotic. And then drafting, does the checklist utilize natural breaks in workflow? Use simple sentence structure and basic language. So we are okay to use in Hindi, we can stick in Hindi that your staff will check antibiotic pad gaya hai, anesthetist ko pata hai ki is patient ko hypertension hai, pediatrician ne note pad liya hai. So ye sari baatein Hindi mein likhi ja sakti hain. The idea is everybody knows and everybody understands. And validation, have you tried the checklist? Is your checklist easy to use? Is it of any use, or is it adding to your work? And does the checklist fit the flow of work? Detect errors at a time when they can still be corrected? Can the checklist be completed in a reasonably brief period of time? We don't want a very, like we are already, as I said, most of the obstetricians are overworked, so we don't want to add to our work, we want to simplify our work. Have you made plans for future review and revision of the checklist? So they need to be reviewed. Is there any evidence that it helps? So this is being used worldwide. I was checking with my colleagues in United Kingdom. All hospitals it is mandatory to use. You have a big advantage, like in this medico-legal, increasing medico-legal complications, that you have a safety checklist in place for an operation which is most commonly done by most of the obstetricians. So Royal College issued a statement in 2011 endorsing its use, and maternity hospitals are using it. Some private hospitals do use it in India, we're checking, but still the use is not very widespread. As when I asked to raise the hands, very few hands went up. Again, this is to quote, I think I have less time, but a lot of evidence has showed that it improves the outcome in maternity units. And this is being validated, I think Pushpa is here. So there are many studies from India, from Karnataka, where they have validated the use of childbirth checklist. There are many studies. So just to conclude, the checklist is not just ticking the boxes. It should inculcate change in the work culture. One of my anesthetists, he would always say in every operation, tetra, tetra, tetra. So this is a very good thing, because when I go back to the cases where the swab was left, these are the cases where, the massive hemorrhage happened and everybody was stressed and they needed a cesarean hysterectomy. So you will not have complication every day. But to minimize it to the minimum, checklists are a very good tool and we should all use it. So the goal is embracing a culture of teamwork and discipline. And you just, as I said, it adds only 2 minutes to improve your outcome, and it can be modified according to the workload, type of team, and other local issues you have. Like just now, Dr. Deepti Agrawal highlighted the parts of the neonatal care. So your checklist can, like if you're missing on vitamin K, just checklist the vitamin K. Eye checkup you have including, was the eye checked before the discharge? So on and so forth. Like many, if you go read, they say that it is not the very complex task give to better results. Simple things lead to much more satisfying and better outcomes in life as well as in our clinical practice. And before I conclude, I got interested in checklist. There's a very good book which I will recommend. It is by Professor Atul Gawande. It is Complications, that is Notes of a Surgeon. It is very good read, like you will, it is not a heavy reading, very good, you can finish it in an hour or so. So with this, I conclude, and I thank the chairpersons, and I thank the members of audience for patient listening.
Thank you, Dr. Poonam. That was a very enlightening talk on checklists. You're right, surgical checklists are not difficult at all. They look very daunting in the beginning. We have been using it with us right from the beginning, and it does help. So I think as a sort of an initiative, we could start it with among the members of our society so that we could promote it.
Yes, something like a pilot study, and then...
May I call upon the speakers of this session, Dr. Pushpa Chaudhary and Dr. Deepti Agarwal and Dr. Alka Pandey, madam, please.
In the meanwhile, I would just like to let everybody know Dr. Poonam Goyal is going to be speaking in the other hall right away. So if you could go to the other hall, if you would like to listen to her, you can see Dr. Poonam just making her way to that hall. Thank you.
Geeta, please present a certificate of appreciation to Dr. Alka Pandey. Dr. Pushpa Chaudhary from Dr. Hemali H. Sinha. I think they were colleagues during their postgraduates, yeah. And Dr. Deepti Agarwal, please, Dr. Basab to do the honors. And let's have a group picture, please.
Thank you so much. With that, I would also like to move to this just one session which is going to be before lunch. We have got the chairperson, Dr. Saroj Singh, Dr. Meera Jha, and we've also got our speaker, Dr. Usha Sharma. Can I request the speaker to please join us on the dais? And Dr. Saroj Singh and Dr. Meera Jha as the chairpersons. Just to let also everybody know, the lunch is being served and we're going to start the post-lunch session bang on time, which is at 2 o'clock. Thank you. Can I request the chairpersons to please join us? Dr. Poonam, Dr. Alka, if you could just give way for the next talk. Dr. Pushpa, Dr. Niba, if you could make some way for the talk. Chairpersons, over to you.
Yes. Our topic is chicken pox in pregnancy. And I would like to introduce Dr. Usha Sharma, who is the speaker. Dr. Usha Sharma is the immediate past president ISOPAB 2022. She is the consultant obstetrician and gynecologist, SK Memorial Hospital and AK Memorial Nursing Home. She is the honorary consultant, Red Cross Polyclinic, Patna, and she has delivered keynote addresses and scientific deliberations. And she has contributed chapters in FOXY and former East Zone Fellow Representative, RCOG. Just a brief introduction to the topic. This chicken pox is actually a live attenuated virus and so should not be given during pregnancy. The chicken pox is a DNA virus of the herpes family, and infected women should be isolated and they should notify to the doctors. Now the rest of the portion will be talked by Dr. Usha Sharma. Please, doctor.
First of all, I congratulate Dr. Alka Pandey and her whole team for this grand Labourcon conference. Now, I will start on my topic. Nikhil, you can start the timer now. Respected seniors, chairpersons, my friends, and colleagues. Chickenpox is caused by varicella zoster virus, VZV. VZV is a DNA virus of the herpes family that is highly contagious and transmitted by respiratory droplet and by direct personal contact with vesical fluid or indirectly via fomites, skin cells, hair, clothing, and bedding. The human is the only source, this is to be noted. The virus enters to the host through the conjunctiva and mucous membrane of the nasopharynx. Maternal infection during pregnancy can have serious maternal, fetal, and neonatal consequences. The incidence of chickenpox is not precisely known as it is not a notifiable disease. Best estimates suggest an incidence of 2 to 3 per thousand in the UK. In US, the incidence is 1.6 to 4.6 per thousand pregnancies. Women from tropical and subtropical areas are most likely to be seronegative for VZV, IgG, and are therefore more susceptible to the development of chickenpox in pregnancy. Chickenpox is caused by varicella. Oh, I have gone back, sorry. Clinical course of chickenpox infection. Chickenpox characterized primarily by fever, malaise, and a pruritic rash that develops into crops of maculopapules which become vesicular and crust over before healing. The incubation period is between 1 and 3 weeks. The rashes may first show up on the chest, back, and face, and then spread to entire body, including inside the mouth and genital area. The disease is infectious 48 hours before the rash appears and continues to be infectious until the vesicles crust over, usually within 5 days. Primary infection usually provides lifelong immunity. Sequelae of chickenpox. Following the primary infection, the virus remains dormant in sensory nerve root ganglia but can be reactivated to cause a vesicular erythematous skin rash in a dermatomal distribution known as herpes zoster, also called zoster or shingles. Maternal risks. Clinicians should be aware of the increased morbidity associated with varicella infection in adults, including pneumonia, hepatitis, and encephalitis. This is apart from the fever and general illness. Women should be advised that the risk of spontaneous miscarriage, this is also important to note, does not appear to be increased if chickenpox occurs in the first trimester of pregnancy. Rarely, it may result in death. Now we come to the fetal risks. IUGR, low birth weight, congenital varicella syndrome. Multiple cohort studies have reported that about 0.91% of fetuses will develop in the first 20 weeks of pregnancy. No cases of CVS has been reported following maternal chickenpox after 28 weeks of gestation. The clinical features of CVS are multisystem, but tissues and organs are selectively damaged. As you can see in this picture, this is obviously an intrauterine death due to CVS, chorioretinitis, congenital cataract, microphthalmia, neurological abnormalities, cerebral cortical atrophy, microcephaly, mental retardation, dysfunction of bladder and bowel sphincters, limb hypoplasia, fetal growth restriction, skin scarring in the dermatomal distribution. A total of 15% cases develop herpes zoster by age of 4, mortality rate up to 30% in affected fetuses of CVS. Diagnosis in the pregnant mother. History of exposure. This is what we usually do clinically, fever and rash, which is typical of chickenpox. Laboratory confirmation, detection of viral DNA by PCR is the most sensitive method for confirming a diagnosis of varicella in the use of polymerase chain reaction to detect in skin lesions, vesicles, scabs, maculopapular lesions, testing of skin scrapings from the base of a vesicle. Immunofluorescence detection of varicella antibody, viral culture in vesicular fluid, which is basically for research purposes. Prenatal diagnosis of the fetus. USG at least 5 weeks after the infection or lapsed after maternal infection, then fetal ultrasound and imaging should be performed. The USG findings are hyperechoic foci in the liver, heart, brain and bowel, hydrops, FGR, prosencephaly, polyhydramnias, limb deformity and contractures, cardiac malformation, ventriculomegaly and microcephaly. Prenatal diagnosis, the second one is fetal magnetic resonance or MRI, may provide additional information in the cases where USG has identified morphological abnormalities. To detect the extent of lesion, we have to do MRI. Otherwise, USG is good enough. Amniocentesis should be performed until 1 month after infection. Amniocentesis should not be performed before the skin lesion have completely healed. Viral DNA can be detected in amniotic fluid by PCR. The presence of viral DNA has a high sensitivity but a low specificity for the development of fetal varicella syndrome. A negative PCR is reassuring but not confirming. Pre-pregnancy prevention of chickenpox. Pre-pregnancy vaccination is the best way to prevent varicella syndrome. Varicella vaccination pre-pregnancy or postpartum is an option that should be considered for women who are found to be seronegative for varicella antibodies. Immunity from the vaccine persists up to 20 years of life. Highly effective varicella vaccine contains live attenuated virus derived from Oka strain of the virus that prevents 98% cases of varicella. Following its introduction, the incidence of primary infection in the general population has fallen by over 80%, and the mortality related to the condition has decreased by 2/3. If a woman of reproductive age is vaccinated, she should be advised to avoid pregnancy for 4 weeks after completing the 2-dose vaccine schedule to avoid contact with susceptible pregnant women should a post-vaccination rash occur. If the pregnant woman is not immune to varicella and she has had a significant exposure, she should be offered varicella immunoglobulin. Unfortunately, this is not available in India, but we should know about it. This immunoglobulin is effective when given up to 10 days after contact. In the case of continuous exposure, this is defined as 10 days from the appearance of the rash in the index case. Non-immune pregnant women who have been exposed to chickenpox should be managed as potentially infectious from 8 to 28 days after exposure if they receive the immunoglobulin, and 8 to 21 days after exposure if they do not receive it. A second dose may be required if a further exposure is reported and 3 weeks have elapsed since the last dose. Even in the Western country, this immunoglobulin is pretty expensive and there is a shortage. So only in selected cases where it is mandatory to be given is given to the patients. Varicella immunoglobulin has no therapeutic benefit once chickenpox has developed and should therefore not be used in pregnant women who have developed a chickenpox rash. Now we come to the treatment part. Pregnant women who develop a chickenpox rash should immediately contact their doctor. Women should avoid contact with potentially susceptible individuals, other pregnant women and neonates until the lesion have crusted over. This is usually 5 days after the onset of the rash. Symptomatic treatment and hygiene is advised to prevent secondary bacterial infection. Oral acyclovir should be prescribed for pregnant women with chickenpox if they present within 24 hours of the onset of rash and if they are 20 weeks plus of gestation or beyond. Antiviral therapy. Acyclovir is a synthetic nucleoside analog of guanine, highly specific for cell infected by varicella or HSV. Acyclovir is not licensed for use in pregnancy, and the risks and benefits of its use should be discussed with the woman. A randomized controlled trial has shown that acyclovir administered orally 800 milligrams, it's a hefty dose, for 5 times a day for 7 days, reduces the duration of fever and symptomatology of varicella infection in immunocompetent adults. There is a clause to it. If commenced within 24 hours of developing the rash when compared to placebo. Intravenous acyclovir should be given to all pregnant women with severe chickenpox. Use of acyclovir before 20 weeks in severe cases can also be considered. Another antiviral drug we can use is valacyclovir, is a prodrug of acyclovir. As a prodrug, it has a longer half-life and better oral absorption and bioavailability. So due to less frequency of administration, is a better choice of oral therapy with improved compliance. Not freely available in India. The dose is 1 gram 3 times daily. Care during delivery. The timing and mode of delivery of pregnant women with chickenpox must be individualized. Depending on the severity of the Now, should I continue or I can discontinue? It's up to you. Continue, fine. The timing and the mode of delivery of the pregnant woman with chickenpox must be individualized depending on the severity of the maternal condition. A respiratory physician and intensive care specialist may be involved in peripartum care. Delivery during viremic period while the chickenpox vesicles are active may be extremely hazardous. Delivery may precipitate maternal hemorrhage and or coagulopathy due to thrombocytopenia or hepatitis. There is also a high risk of varicella infection of the newborn with significant morbidity and mortality. Supportive treatment and intravenous acyclovir are therefore desirable, allowing resolution of the rash, immune recovery, and transfer of protective antibodies from the mother to the fetus. Ideally, a minimum of 7 days should elapse between onset of rash and delivery. However, delivery may be required to facilitate assisted ventilation in cases where varicella pneumonia is complicated by respiratory failure, and obviously the mortality is over 50% in such cases. Precautions during anesthesia. General anesthesia may be exacerbate the respiratory compromise associated with varicella pneumonia. There is a theoretical risk of transmitting the varicella zoster virus from skin lesion to the central nervous system via spinal anesthesia. As the dura is not penetrated, epidural anesthesia may be safer than spinal anesthesia. However, the larger needle required for epidural anesthesia carries the theoretical risk of transferring a greater viral load from the skin to the epidural space. When epidural or spinal anesthesia is undertaken in women with chickenpox, a site free of cutaneous lesions should be chosen for needle placement. If maternal infection occurs in the last 4 weeks of woman's pregnancy, there is a significant risk of varicella infection of the newborn. A planned delivery should normally be avoided for at least 7 days after the onset of maternal rash to allow the passive transfer of antibodies from mother to child, provided that continuing the pregnancy does not pose any additional risk to the mother or the baby. A neonatologist should be informed of the birth of all babies born to women who have developed chickenpox at any gestation during pregnancy. This is also very important. Now we come to the postnatal diagnosis in the fetus or in the baby now. History of first or second trimester maternal varicella infection, fetal abnormalities consistent with congenital varicella, evidence of intrauterine varicella infection, detection of varicella DNA in newborn, presence of IgG antibodies, appearance of clinical zoster early in infancy, persistence of one more minute.
Just
and it's
one
done.
announcement I'll make and then you can continue. Just wanted to let everybody know that the post-lunch sessions are going to start at 2 o'clock no matter what. But you can definitely listen
Just
to
one
ma'am.
minute, 1 minute.
And yes,
only
that's
one
all.
more minute. This is last 2 slides. Persistence of varicella IgG antibodies for more than 7 months after birth. Now we can skip this. Skip this. Breastfeeding. Women with chickenpox should breastfeed if they wish to and are well enough to do so. If there are active chickenpox lesions close to the nipple, they should express breast milk from the affected breast until the lesions have crusted over. The expressed breast milk may be fed to the baby who is receiving treatment with varicella immunoglobulin and or acyclovir. The take-home message is ideally women should be screened for varicella immune status prior to pregnancy. Seronegative women should be vaccinated prior to pregnancy. Seronegative women exposed to varicella during pregnancy should be given varicella immunoglobulin within 10 days of exposure if we can detect that. Once varicella develops, oral acyclovir reduces the severity of clinical disease. In severe varicella with pneumonia, IV acyclovir should be given. If mother develops varicella around delivering, newborn should be given both intravenous immunoglobulin and IV acyclovir. Finally, seronegative women should be vaccinated in immediate postpartum period. Thank you for this overtime patient hearing.
Yes, ma'am. If you could come at the center also, we would like to give you a token of appreciation.
You have dealt very elaborately and very nicely on this very important topic. And points to be kept in mind are that if a patient comes and there is a chickenpox rampant all around, then she should be asked about close contact. If she has close contact and says we don't have immunoglobulins available, she should be kept in isolation and not go to other pregnant ladies, and she should be under close surveillance. If she develops chickenpox, then depending on the period, if she's above 20 weeks, oral acyclovir may be given, and she should be properly kept in proper surveillance and all. And
कहाँ गई अलका? हाँ बस आ जाओ
take while you examine a pregnant with chicken pox? What are the precautions?
Now, can I request Dr. Alka Pandey ma'am to please join us on the stage, as we would like to present a token of appreciation to Dr. Usha Sharma ma'am, along with the chairpersons. Dr. Alka Pandey ma'am, bhi to announce kiya. We would also like to give a token of appreciation to the cultural committee and all the contestants from the pageant show as well. Dr. Alka Pandey ma'am, Dr. Alka ma'am, please stage पर आइए ना. Requesting Dr. Vinita Singh ma'am also to please join us on the stage. Requesting Dr. Ruma to please come forward, as we would like to have your assistance while we... Dr. Lakshmi, she was there, definitely there as the MOC, helping us out, and today also she is there, and we would like to thank her. She's wearing a beautiful bronze sari. I hope the color is pronounced right, because the colors go crazy. डॉक्टर अलका मैम, आपको स्टेज पर ही रहना है, बिकॉज वो सर्टिफिकेट्स दे रहे हैं कल्चरल प्रोग्राम के. थैंक यू सो मच. डॉक्टर विनीता दी, आप भी प्लीज वो सबको कल्चरल सर्टिफिकेट्स दे रहे हैं, मोमेंटोस दे रहे हैं. Certificate of participation. And we are giving the pageants show prize to... Can I request Dr. Pragya Mishra ma'am to please join us on the stage? Can I request Dr. Ritu also to... Can I just request Ritu also to just be there? She's got a certificate. उनको सिर्फ फोटो चाहिए आपके साथ स्टेज पर. Yes. डॉक्टर नीलम, डॉक्टर अलका, एक फोटो सर्टिफिकेट है, सिर्फ ऐसे पकड़ते हुए हमको एक फोटो चाहिए आपके साथ. Thank you so much. Is there anybody else from the cultural committee? Lunch, Doctor. She's worked really hard, yes. और सच में किया भी है, ऐसा नहीं कि हम सिर्फ बोल रहे हैं. नहीं कुछ. थैंक यू. डॉक्टर रंजना मैम, इफ यू कुड जॉइन अस ऑन द स्टेज. सर्टिफिकेट मैं दे देता हूँ. Professor Rita. ठीक है तो पक्का फिर से दिल, एक ही तो दिल है, कितनी बार जीतोगे? डॉक्टर सुप्रिया, प्रोफेसर रीटा सिन्हा मैम हैज एग्रीड टू. मुकुंद भैया क्या कर रहे हो? वही लिखो, ये सब हटाओ. हाँ उधर से हरी वो सब वॉल्यूम देख. हाँ.
Check. Hello, hello.
So post-lunch session we are having first speaker Dr. Rita Sinha. She is Dr. Professor Rita Sinha. She is consultant at MGM Hospital and Research Center, Patna. She is a senior most out there and she is a very active member of many societies. Madam has got great academic acumen, and then Madam has got many things to her credit. She was the president of Patna ISOPAB. And Madam is a very active member and very close to MGM Madam, and I have been her student when I was working in her unit. So thank you. Over to you, Madam.
Respected chairperson, my senior and junior colleague, first of all I am thankful to the organizer Dr. Alka Pandey and Dr. Abha Rani Sinha for giving me the opportunity to talk in front of you about peripartum hysterectomy. Peripartum hysterectomy is defined as hysterectomy performed as a life-saving procedure. At the time of delivery or up to 6 weeks postpartum period following vaginal delivery or cesarean section. INOS means International Network of Obstetric Service System has defined as surgical removal of uterus from 22 weeks of pregnancy up to 42 days of postpartum period. It is performed by Poro in golden year of 1871. The incidence is due to past disorder. Worldwide, peripartum hysterectomy occurs 71.6% to 82.61% past disorder, and in India it is 0.24 to 8.9 per 1000 delivery. This is more in developing country because of increased population, increased birth rate and lack of proper monitoring facilities. So the caesarean rate is increased, which cause placenta previa and increased placenta spectra syndrome. Obstetricians should be aware of difficulty of emergent condition and improve its and diagnosis rate, and expert skill is required. The PAS is also increased after IVF because altered hormonal milieu increase the estrogen, elevated estrogen level at the implantation and causes trophoblastic invasion deep inside the myometrium. But in IVF with lower serum estrogen, presence of thinner desudalized may cause PAS endometrium. This is the cause of PAS, placenta accreta and percreta in primigravida with advanced age or IVF pregnancy. In cryopreserved embryo, increase 4 to 13 times risk of PAS disorder. The indication of peripartum hysterectomy, the commonest being the uncontrolled uterine bleeding delivery following cesarean section or vaginal. Causes are uterine atony 20 to 40%, PAS disorder 30 to 60%, uterine rupture in previous cesarean section 5 to 10%, sepsis 10 to 15%, injury to uterine vessel, extension of cervical tear, chorioamnitis and fibroid with pregnancy is indication according to time of surgery. It may be emergency, it may be indicated or it may be elective. Anatomical indication, it is supracervical, subtotal, total or radical. Clinically indication is planned when diagnosed pre-operative period by ultrasonography that the mother is suffering from PAS disorder. And in emergency, the PPH occur due to cesarean section or vaginal delivery. And in postpartum period, if due to sepsis, due to chorioamnitis, peripartum hysterectomy is done. There is a question mark on salpingo-oophorectomy depending on the age of the patient. If patient is younger, tube ovary is usually left, but nowadays the fimbria is cut due to prevention of ovarian cancer. And if the anatomical distorted, salpingo-oophorectomy is performed. The management part depends upon diagnosis, investigation and treatment. Diagnosis is done in antenatal period, ultrasonography is gold standard, high accurate color Doppler and 3D power Doppler is increased sensitivity is there. MRI is done to useful access depth of biometrial invasion and for parametrial involvement. But in cases of where the patient is obese and the placenta is posterior, MRI is very important. Biomarkers, important tool for PAS as it is altered. At 11 to 12 weeks, beta HCG decrease and PAPA is increased. And for 14 to 20 weeks, elevated maternal serum alpha protein, beta HCG is lower and PAPA is higher. Then we can think that it may be a case of PAS disorder. Intraoperative, when we open the abdomen, the presence of engorged vessels in the lower segment, just like a earthworm, it is a good indication of placenta previa, placenta accreta. Possible predictive clinical sign, difficult manual or piecemeal removal of placenta, absence of placental separation, 20 to 30 minutes after delivery despite of active management. And retained placenta fragments require curettage, severe bleeding from placental bed. Prerequisites for peripartum hysterectomy are, most important is multidisciplinary approach should be there. Blood bank including availability of alternative blood products should be there. Experienced obstetrician, accompanied pelvic surgeon, urologist, interventional radiologist, ICU facilities, NICO is very important. And most important is written and informed consent of guardians should be taken. Investigation as other hysterectomy or cesarean section, CBC, blood group, coagulation profile is done. Preoperative requisite is the two central lines should be placed, two large bold IV lines should be there, and catheterization is maintained in urethral and ureteric to prevent injury to the bladder and ureter intraoperatively. Points to be highlighted while doing procedure. Anesthesia is epidural or spinal anesthesia should be there. Vertical incision preferred for adequate exposure. Many times transfer has to be converted into malod incision for better exposure. Peritoneum is opened high up to prevent injury to urinary bladder. And hysterotomy means baby is to be taken out by giving incision to fundal region of the uterus, not touching the placenta. The separation of round ligament is done, clamp, cut and suture, broad ligament is separated, dissection of bladder and perivascular space is done, and palpation and clamping and separation of cardinal ligament and uterine arteries are done. Separation of uterosacral ligament is done and closure of vaginal curve is done in the last. And all the hemostasis should be seen that it is controlled. It is the common indication that placenta accreta in the uterus, it is attached, cord is attached. These are the procedure of hysterectomy. Uterus is elevated by placement of clamps across the broad ligament, including round ovarian ligament and tubes. This is round ligament, tubes. Bladder immobilization is done. So, difficulties which a surgeon can face intraoperatively are, space is restricted due to big uterine size. Difficult to identify softer tissue. Lower segment is elongated, blood vessels engorged, massive hemorrhage obscure the operative field. Tissue vessel wall are edematous, may lead to losing of ligature in post-operative period. So, double suture should be taken. An injury to the bladder can be prevented by filling bladder with 300 ml of methylene blue to identify superficial margin of bladder. Ureter stent can be done to prevent ureteric injury. This is a diagram showing placenta accreta. This is also some other patient. Procedure to be followed to prevent intraoperative complication in emergency with an unstable patient, clamping the uterine blood supply rather than adenolysis, and pedicles rapidly clamped, cut and dropped and subsequently sutured. In case of bladder invasion, cystostomy is performed with resection of the affected portion of posterior wall of bladder in block uterus followed by bladder repair is done. This is also a case of placenta accreta. Post-operative is a stable patient as in any other hysterectomy. Unstable patient need ICU care. Prophylactic antibiotics is given and thromboprophylaxis is done. So to conclude, it is a life-saving surgery, difficult and different, tissue soft and friable, vessels dilated and distorted, quick but meticulous. So planned is better than emergency, total hysterectomy is better than subtotal, a tertiary care with all facilities should be there, avoiding iterotonic agent. If you have diagnosed already placenta accreta percreta, iterotonic agent should not be given because it causes partial placental separation leading to severe PPH. Clamping and controlling bleeding at priority. Post-operative care is important. Diagnosis by antenatal imaging and multidisciplinary team approach for the management of a strategy. With prudence and preparedness, we can overcome the problem. In peripartum hysterectomy, the death rate is 1%, whereas in non-obstetrical hysterectomy, death rate is 0.04%. So saving life is more important than saving uterus. Thank you.
Thank you, madam. It was a very elaborate and descriptive speech by you. And everything was very nicely explained. The most two important things which we should consider is saving the patient's life and taking care of the hemorrhage, and the third part is saving the bladder and the ureter. I think that's the everything has been dealt by you very nicely. Thank you very much, madam.
Thank you, Chairperson.
Thank you, Rita Di. The way you used to teach us, every steps you have collaborated in your speech also, every steps of operation. So very well done. Thank you very much. Thank you.
The next we have Dr. Monica Anand.
Yeah, I have a CV. So it's a pleasure to invite Dr. Monica. We've seen her grow, and now she's an associate professor, additional professor at AIIMS Patna, and she's going to be talking to us on acute fatty liver of pregnancy, a catastrophic emergency it can be. All yours.
Thank you, respected chairpersons. Good afternoon, everyone present in the hall post lunch. And today I want to thank first of all the organizing chair of the conference, Dr. Alka Pandey ma'am, and Dr. Abha ma'am, the scientific chair, for giving me this opportunity to talk on this platform. And I would be talking on acute fatty liver of pregnancy. As we have seen over the few years, the incidence has definitely increased, or maybe our capacity to diagnose this condition has increased. Earlier we used to stamp all cases of jaundice in pregnancy as jaundice in pregnancy, and we knew that the outcomes were poor. So acute fatty liver of pregnancy is an acute obstetric emergency, and it is characterized by some level of maternal liver dysfunction or even failure that can lead to maternal and fetal complications, including death. The incidence reported is 1 in 7,000 to 1 in 20,000 pregnancies. Prompt delivery, supportive maternal care are very important for achieving a full recovery for the mother, and therefore the rates have now decreased from more than 75% to less than 5%. This is the rates of mortality for AFLP. The risk factors we know are that there is a deficiency of the fetal long chain 3-hydroxyacyl coenzyme A dehydrogenase enzyme, homozygous for the fetus. There has been a prior episode of AFLP. There might be multiple gestation, which increases the risk 14 times. Preeclampsia or HELP can be associated with AFLP, and they have overlapping features. We'll see in the forthcoming slides that how we can distinguish between the two. The male sex of the fetus also increases the risk of AFLP. Low body mass index in the mother and nulliparity, they also have an increased risk. So pathophysiology of AFLP is not clearly understood, but most likely it is an impaired mitochondrial beta oxidation of the fatty acid, which is caused by the enzyme deficiency in the fetus. So fetus is homozygous. There is increased free fatty acids metabolites that will cross into the maternal circulation. The pregnant woman who is heterozygous for these enzymes, they are more susceptible to the increased levels of metabolites, to liver injury from these lipotoxic ones. Inflammatory pathway activation is more in them. Reactive oxygen species are built up more, and there is apoptosis of the liver cells, that is the hepatocytes. This is the same picture that has been depicted, and we see therefore then when the fetus and the placenta is delivered, the maternal health will improve dramatically after its delivery. The patient usually presents typically between 30th to 38th week of gestation, but reports have been seen as early as 18 weeks or as late as 4 days after delivery. The initial symptoms are usually non-specific, with nausea, vomiting, abdominal pain, malaise, headache, anorexia. There might be hypertension. HELP is seen in 20% of the patients of AFLP and preeclampsia in 20 to 40%. These symptoms will rapidly develop into acute liver failure, jaundice, ascites, encephalopathy, DIC, and hypoglycemia. Also seen to be associated very much with AFLP are acute kidney injury and multi-organ failure. The other presentations can be in the form of acute pancreatitis or central diabetes insipidus, now known as arginine vasopressin deficiency. So why does AFLP present late in pregnancy? Because the heterozygous defect of the fat utilization, that is masked and asymptomatic in early trimester, when the main source of energy for the mother is the glucose metabolism. As third trimester approaches, the metabolism changes for the mother from glucose to more fat metabolism, because the demands of the fetoplacental unit is manifold increased. So the manifestation of acute liver failure occurs in later pregnancies. These are the few features of AFLP which we can see: encephalopathy, nausea, vomiting, anorexia, epigastric pain, GI symptoms, hemostatic dysfunctions, liver failure leading to hypoglycemia, jaundice, decreased procoagulant synthesis, uteroplacental perfusion is reduced, affecting the baby, and acute kidney injury. Studies have been done to predict how we can diagnose the AFLP earlier by some diagnostic test, and it has been seen that if gastrointestinal symptoms are associated with increased aminotransferase, bilirubin, bile acids, PT, APTT, then it is 97.6% sensitive to diagnose AFLP. The most important criteria used to diagnose clinically is an amalgamation of sign symptoms, laboratory findings, imaging, and histology. Was given by Chang et al. In 2000, and it has been validated also. So sign symptoms which we see are vomiting, abdominal pain, polydipsia, polyuria, encephalopathy, already we have seen that, and laboratory findings of elevated bilirubin, which is more than 1, hypoglycemia less than 72, glucose level in the blood, leukocytosis, 11,000 counts of TLC, elevated transaminases, usually they are more than 5 to 10 times the normal values in pregnancy, elevated ammonia, elevated urate, AKI where the creatinine will be more than 1.7, and coagulopathy where the PT will be raised more than 14 seconds. These criteria can only be used in patients in whom HELP and preeclampsia has been excluded. So these are the percentages in which the conditions are seen. If you see, in more than 85% patients of AFLP, there is increased WBC, abnormal liver function tests, and abnormal blood coagulation tests. Imaging is not diagnostic. Only if the clinical and laboratory picture is unclear or the diagnosis is uncertain, we may go for imaging, in which ultrasound you can see fatty infiltration, brightness, and a few non-specific changes. MRI also shows a transient increase in the detectable fat, which actually resolves 2 weeks post-delivery. Is liver biopsy indicated? No, not at all, not necessary for diagnosis. If, however, the diagnosis is unclear and it is very imperative to know the cause, then we can go for a liver biopsy. Only thing is you have to see that the coagulation profiles are normal. What are the differential diagnoses that come to our mind when a patient with AFLP come? First is the HELP and severe preeclampsia, hepatitis and other viruses, and some toxins. Signs of hepatic insufficiency like hypoglycemia, encephalopathy, ascites and coagulopathy are definitely more consistent with AFLP, and multi-organ involvement like AKI is also more common with AFLP. So if you want to differentiate between AFLP and HELP, we need to see the order of change in the laboratory findings. In HELP, you will find early thrombocytopenia. In AFLP, thrombocytopenia is lesser and late. AST is proportionately decreased as platelets in HELP, but AST is disproportionately elevated in thrombocytopenia. Fibrogen decrease and PT prolongation is lesser in cases of HELP, but it is much more coagulopathy in AFLP. And this will differentiate. AKI, CNS findings, and total bilirubin increase is also very much more in AFLP cases. So how should we diagnose? Definitely using the Swansea criteria for diagnosing, because it has been seen to be consistent 97% of the times, and when it has been validated with the microvesicular steatosis found on liver, then it has been found to be 100% sensitive and having a negative predictive value of 100%. So a study from South India has also given a simplified criteria for the diagnosis of AFLP, where in late pregnancy, in second or third trimester, if there is acute liver failure, jaundice with coagulopathy or hypoglycemia and or encephalopathy with no other explanation, then you can stamp the case as AFLP. Initial management, prompt delivery of the fetus regardless of the gestational age. So patients with signs and symptoms of acute liver failure should be transferred to a referral center for liver transplantation evaluation. This will come to later, where the parameters are not improving when we have given the appropriate.
Insulins are the NPH that we have all used. The newer ones are Detamir and Digludac, and the bolus insulin is the regular insulin, and the newer analogues are Lispro and Aspart. As you can appreciate here, the Lispro and Aspart, you have to take it at the beginning of the meal, and the peak of action comes in 1 to 2 hours, and the action will last only for 4 to 5 hours. So what happens is that when the patient eats, there is a hyperglycemia at 1 to 2 hours, and this will come down by 4 hours. And the regular insulin, it is going to act for about 6 to 8 hours. So between this 4 hours to 8 hours, there are chances that the patient will get into hyperglycemia. So the advantage of these rapid acting insulin is that it acts for a shorter while, so there is no hypoglycemia. And can you see this, the Glargine and the Digludac, the Detamir, and there is a new analog also, Digludac. So these ones do not have a peak. So there is no chance that the patient will have hypoglycemia. So these are the insulins which have been found to be safe and recommended for use in pregnancy. So what we do is, once the patient is detected to be having impaired glucose or GDM, we admit the patient and we do a 7-point profile. And the targets, madam has already told us, whatever value is above the targets, we calculate all of that and we divide it into 2/3 in the morning and 1/3 in the evening. So in that way, in the beginning we are doing 7 samples, but once we achieve a normal target values, then there's no need to do it 7 times. You can just do it fasting and postprandials. If the patient is not willing to do that, she can do a staggering approach. That is, एक दिन fasting, उसके बाद breakfast, next day post lunch, next day post dinner. तो इस तरीके से you will be able to capture the whole glycemic profile. And another thing is कि glucometer से कई बार गड़बड़ reading आती है. So once a week we should get the fasting and PP done in the lab. So again I want to show you this very interesting thing. This is the continuous glucose monitoring system which is known as the Freestyle Libre Pro by Abbott. This is a very simple device which I have used personally for my patients in Lady Harding, a public hospital. इसमें क्या है? There is a reader and this is a sensor. This is just a 10 rupee coin sort of thing which is put here. इसमें बहुत छोटे छोटे sensors में mosquito के जैसे prongs हैं which will go into the interstitial fluid. And just imagine 14 days का you will get a blood sugar profile in this graphic form. So just to elaborate, this patient came to us at about 6 o'clock, and as you can see, the average glucose it is giving as 218. Time in target, this is fixed, we can fix it between 80 to 140. इसका 0% time in target था. Then time below target was 0%, no episode of hypoglycemia, and time above our target is 100%. This patient developed vomiting, and can you appreciate here these red lines? This is 56% of the time she had hypoglycemia, 25% she had normoglycemia, and 19% she had hyperglycemia, this yellow one. And the next day, because of vomiting and starvation, as madam was just enumerating, she went into DKA, diabetic ketoacidosis. And this measures levels only till 350. So it went till 400. And her average blood glucose, if you can see, is 272. 6% of the time she was normoglycemic, 0% hypoglycemia, and 95% of the day she had hyperglycemia. So it is an excellent device. This comes for 2,000 rupees only, and the reader is 5,000. So if you can buy it and you ask your patients to use it for this sensor, they have to buy. For 2 weeks, it will give you, without breaks, without any inconvenience, all the glucose profile. So this is a newer initiative.
Sorry.
This is known as Freestyle Libre Pro.
Freestyle.
Even people who are not pregnant or people like us who are prone to become pre-diabetic or diabetic later on, we can use this. And what I see is, हम केला खाते हैं, rice खाते हैं, उसके बाद immediately 1.5 से 2 घंटे के बाद you are getting a peak. So it is an excellent self-educatory tool which can be used by all of us. Not a very difficult thing. Diabetologists are using, why not us? We can use it on ourselves and then try it on our patients.
Sure.
मैडम जो छोटा सेंसर है जो पेशेंट को खरीदना है वो सिर्फ 2,000 रुपीज़ है, और जो आप खरीद के रखेंगी रीडर जो उसको स्कैन करेगा वो 5,000 है. तो आपका लाइफ टाइम इन्वेस्टमेंट इज 5,000 एंड पेशेंट फॉर 2 weeks हैज टू स्पेंड ओनली 2,000. तो वी आर यूजिंग इट इन ईच ट्राइमेस्टर, क्योंकि उनके ग्लूकोजेनिक हार्मोन्स बनते हैं, ब्लड शुगर हाई जाते हैं, तो हर ट्राइमेस्टर में हम एक बार करके उनको समझा देते हैं. सो डॉक्टर शांति, in your clinical practice, do you advise metformin or glyburide?
Excuse me, ma'am, I advise insulin according to the ACO guideline and American Diabetic Association, WHO, and also Government of India guideline in GDM. So I will prefer insulin.
I would like to ask the other panelists, is anybody using metformin in pregnancy? Yes. Ma'am, what is your experience with metformin?
And when do you start metformin? At what period of gestation?
We are using it frequently, and it is good. But
Do you start in first
the
trimester?
government of India recommends not before 20 weeks. But what do you continue?
So the thing is that the government guidelines, the national guidelines recommend that metformin can be used after 20 weeks.
20 weeks.
Just remember the NICE guidelines. What do they say? You can use it throughout pregnancy. None of the regulatory authorities all over the world have given permission for metformin to be used during pregnancy. But very recently, एक regulatory body है Europe की, which is known as the European Union, which is a very stringent, very strict body, that has recently given permission for metformin to be used in pregnancy. This is the one. So, इसको आप पढ़िए. In European Union, they have said that metformin is the first oral anti-diabetic drug which was used as an anti-diabetic medication to be used safely from conception to birth. So now, from conception to birth, there is no doubt that it can be used. एक और चीज़ है कि मेटफॉर्मिन कैसे यूज़ करनी है. So we know that the side effects of metformin are generally GI symptoms. The advantages, it does not cause any hypoglycemia, it does not stimulate the fetal pancreas, it can be given in breastfeeding. और दूसरी चीज़ है मोटे पेशेंट्स के अंदर, पेशेंट्स who are obese, if you give this, it causes insulin, increases insulin sensitivity. So the dose of insulin which is required for such patients will come down. So that is a very big advantage. But the disadvantage is that 30 to 40% will go into preterm labor and 30 to 40% will not be controlled only on metformin. तो उसमें आपको इंसुलिन ऐड करना ही पड़ेगा. और एक ये जो येलो मैंने मार्क किया है, दिस इज अ वेरी वेरी इंपॉर्टेंट थिंग फॉर ऑल ऑफ अस टू रिमेंबर. इट शुड नॉट बी यूज्ड इन वुमेन विद pre-eclampsia या hypertensive disorders of pregnancy or women who are at risk of fetal growth retardation because it causes growth restriction or acidosis in the setting of placental insufficiency. This is this very important registry based cohort study including a huge number of patients. इसमें ये कहते हैं कि metformin is as good as insulin, but it also increases significantly the risk of being small for gestational age, which suggests caution in pregnancies who are at risk of fetal undernutrition. So जो हमारे patients हैं जिनको hypertension है या abruptio रहता है या पहले उनको previous FGR रहा है, in those patients we should not prescribe. Another very important question is, ma'am, I would like to ask you, do you continue metformin in PCOS patients? Yes.
Yes.
So I think it is a consensus and we have evidence. This is a systematic meta-analysis comprising of 5 RCTs and 7 cohort studies which have found that metformin is not increasing any side effects, and again they say it should be used from conception to delivery.
This is done.
So just in a nutshell, these are all the major bodies: the Ministry of Health and Family Welfare 2018, DIPSI 2023, ACOG 2018, American Diabetes Association 2023, and NICE Guideline 2015. As you can see here, insulin is the first drug of choice, but all these are also recommending that metformin can be used in pregnancy. So coming to case number 3, this is for,
Sure.
This is for Dr. Anupam. Ranchi लिखा था उसमें, so I don't know.
नहीं, इसी अनुपम को मिलेगा, वो नहीं है.
Okay. So this is the second gravida para 1 L1. She presents to you, madam, at 34 weeks of gestation. She had history of GDM, but she delivered a full-term normal delivery baby boy, 3.7 kg. Abhi, she is diagnosed as GDM in this pregnancy and is controlled on MNT with insulin. So how do you in your practice diagnose macrosomia? Clinical practice में हम कैसे करते हैं?
In a clinical practice, if for that particular gestational age, if it is more than 95th percentile, then we diagnose it as a case of macrosomia.
Correct. And as you can see here, it is above the 95th percentile. और AC का भी होता है कुछ?
Yes, ma'am.
हाँ. 2 standard deviations above SD.
Yeah.
Then you say. So, would you like to induce labor before term? मेरे पास जब हमारे residents हैं, 34 weeks पे वो बच्चे बोलने लगते हैं, मैम इसको तो मैक्रोसोमिया हो रहा है, इसको डिलीवर करा देते हैं. So what should we do?
Actually, ideally in cases of diabetic patients, lung maturity is delayed.
Correct.
So our main aim should be prolong the pregnancy with careful fetal surveillance, and our aim should be to prolong at least till 39 weeks, and then we can go for induction of labor if all the other parameters are within normal range.
Very right, very right. Next slide, please. So some of the new markers, एक चीज़ I would like to tell you, both the sonographic and the clinical evaluation have very poor predictive value, 50, 60, 70% at the most. So we need to plot a graph, serial graph of clinical growth and ultrasonography, which will give us a good idea about macrosomia. And these are some of the new markers. इसमें एक नया जो मैंने पढ़ा, bisacromial diameter at the level of heart, if it is more than 15.4 centimeters, or if AC is more than 35.5 centimeters, then it predicts very well macrosomia. The other new ones are transverse fetal thigh diameter, 3D ultrasound, fractional limb volume, subcutaneous fat over the midarm and abdomen. Can it be prevented? So it occurs because of uncontrolled blood sugars and is more in obesity. So although it is manifested in the third trimester, but it sets up in the first trimester itself. तो जो सबसे पहले डॉक्टर आभा ने बोला, preconceptional counseling and good control of weight and blood sugar levels before pregnancy or in the first trimester is the goal.
How to avoid shoulder dystocia?
So as you have rightly said, suspected fetal macrosomia is not an indication for preterm induction, because induction is going to fail and it will end up in cesarean because the biceps is poor. So this is the ACOG practice bulletin number 22 and French College of Obs and Gynae thing. So the indication for elective cesarean before labor is only if the estimated fetal weight is more than 4.5. लेकिन हमारे यहाँ तो macrosomia is 3.4.
I also wanted to say that for in our Indian context, I think we should take it as 4 kg.
It is taken, macrosomia in Indian context is taken as 3.45 kg. So if it is more than that and the lady is big, you can do a feto-pelvic disproportion and then you can decide. Or if she has a previous history of shoulder dystocia, severe maternal or neonatal complication or stillbirth, or she has failure of to progress during labor, या तो descent में problem है या rotation में problem है या second stage arrest है. In those cases, instead of going for a assisted vacuum or a forceps, it is better to go for a cesarean.
Because there are chances of shoulder dystocia also, so
Absolutely.
it's always better to go for a C-section rather than a difficult second stage.
Yes.
Section.
And the head will come out, but the shoulders will get
stuck. Yeah.
So we should be very proficient with shoulder dystocia drill also. So when will you like to terminate? You have rightly said 39 weeks. These are the Caucasian guidelines. But in Indian setup, we do termination between 38 to 39 weeks because Indian babies age faster and there is 5 to 7 times higher risk of stillbirth. We have all had fresh stillbirths, IUDs in the late period of gestation because the placental aging occurs and the placenta is failing. So Dr. Suruchi, at 38 weeks, her Bisher score is 4. Her estimated fetal weight is 3.4 kg. How will you proceed, vaginal or cesarean?
Thank you for the question, ma'am. As a bishop
have
score
only
is
1
poor,
minute left.
as a
One
bishop
question
score
for
is
Sonali.
poor, we will proceed for induction of labor in this case with cervical ripening done with the help of prostaglandins. Yes, ma'am?
Yeah.
And the management will be, we have to take a high risk consent with the to the patient explaining the risk of instrumental delivery or cesarean anytime, and blood has to be arranged. And the night before the induction is carried out, the patient will take a light meal and her insulin dose, and in the morning the patient will omit her meal and the insulin dose. And hourly monitoring of the blood sugar along with input-output charting and urinary ketones will be done. And the target is to maintain the blood sugar between 70 to 100 milligram per dl. And if it goes, 2 IV lines have to be secured. And if the blood sugar goes above 100, we have to start the dextrose insulin neutralizing drip. In one hand, 5% dextrose will be started at 125 ml per hour. And in the next other hand, we have to mix 50 units insulin in 50 ml NS and have to start the infusion. And the dose will be at what units we have to decide by the blood glucose sugar level. At 100 to 140 we will give 1 unit insulin per hour. At 140 to 180 1.5 insulin per hour, and above 180 we will give 2 units insulin per hour.
Excellent. So we don't need to show this. This is a ready reckoner for insulin glucose therapy which can be seen from the national guidelines. So at the end, Dr. Sonali, how will you manage blood sugar levels after delivery and how will you counsel this woman at discharge?
Madam, most of the time the blood sugar levels immediately comes to normal after once the baby is delivered. We will go for a screening of blood sugar which is done immediate postpartum period, that is day 1 to 3. or 4 to 6 weeks, 4 to 12 weeks postpartum, then annual screening, and then it is pre-pregnancy screening. And before discharge, we have to go for the counseling for the effective breastfeeding, for the lifestyle modification. We have to tell all the modifiable risk factors for diabetes. We have to tell there is a risk of type 2 diabetes, over diabetic and type 1 diabetics in the future time, which can be prevented. We have to tell a risk of atherosclerosis also, and besides this, we have to counsel the mother regarding the warning signs of neonatal hypoglycemia also, so that self blood sugar monitoring and self baby awareness is important, so that the mother can have a healthy baby after that.
Excellent, you have covered all the points, but one very important point is that we call her back at 6 to 12 weeks to do a OGTT, so that if we get she is normoglycemia, then also she has to come back every year lifelong. If she is impaired glucose tolerance, we can start either metformin or continue the lifestyle management. Or wahi nahi, her baby is also high risk. So during immunization program, we can catch her there. They have to be told about the chances. 2/3 of them are going to develop GDM in the subsequent pregnancy, and 50 to 70% will develop type 2 diabetes and other NCDs.
Just one point, I think we can continue metformin during breastfeeding also.
Yes.
If she's already on metformin and if she needs some oral hypoglycemic agent, then metformin can be continued even during breastfeeding.
Metformin and glyburide both are
can be
safe
continued,
during delivery. Thank you so
thank
much
you.
for a very interactive session. Thank you. And I want to thank the organizers, Dr. Alka Pandey ma'am and Dr. Abha, for inviting me here in this important meeting.
Definitely, can we take a group picture with all the panelists, experts and the moderators? Can I request Dr. Abarani Sinha to just do the honors and present the certificate? हेलो हाँ मैं निखिल बोल रहा हूँ मेरे पास है आपका फोन आ जाओ नहीं निभा जी नहीं Now we would like to move to our next panel discussion. Can I request the moderator, Dr. Pragya Mishra Chaudhary ma'am, to please join us on the stage, along with Dr. Binu Singh Kushwaha, our expert, Dr. Aarti Kumari, our panelist, Dr. Madhu Singh, Dr. Tabassum Ahmed, Dr. Anita Paswan, Dr. Rashmi Prasad, Dr. Sudvita, Dr. Suniti Sinha, Dr. Asha Dolani and Dr. Sharda.
You can just speak it. You can do it now also. चलो करो, फिर नहीं होगा. शुरू कीजिए. I'll just hold it. Okay, okay. आप शुरू कीजिए. हाँ.
A very good afternoon to all of you all. Please, may I have your attention? हाँ हाँ हाँ.
क्यों भाई? Excuse me. Can I have one more mic अगर मिल जाए?
नहीं,
Afterwards, अच्छा ठीक.
I invite, so this is induction of labor in special situations. Well, something which, a very important subject, though not so commonly used in our country. We still, we think either if someone delivers normally, well and good, next is what, do a cesarean section. And, if you see the practice in the Western countries, especially UK, I mean, they would induce everybody. I mean, wherever vaginal delivery is indicated, they would induce everyone. So, because they feel that, it is her woman's right to deliver vaginally and we should give chance to every woman to deliver vaginally. Dr. Veena, please, thoda sa quiet. So, so I have an esteemed set of panelists here, and my co-moderator, Dr. Binu Kushwa Singh from Riva Medical College, and we have expert Dr. Aarti Kumari as for this panel discussion. So the esteemed panelists are Dr. Madhu Singh from Sitamarhi. We have Dr. Sharda from Ranchi. You can just raise your hand so that people know. Yeah. Dr. Tabassum Ahmed, Dr. Anita Paswan, Dr. Rashmi Prasad, yes, Dr. Sudvita, Dr. Suniti Sinha, and Dr. Asha Dulani from Katihar. So, in fact, we were thinking that our panelists are missing, but I'm so glad that everyone is present for the panel. So, thank you so much, indeed, for being present for the panel. So we would start with, it's a case-based panel. So this is a 32-year-old lady, gravida 2 para 1. She's had one cesarean section for breech presentation at 39 weeks, and this was 5 years ago. Now she decides to go for a VBAC in this pregnancy. Well, because because she had a breech that time, so it's a non-recurrent indication. So this is, and she's 40 weeks now, cephalic presentation, and not gone into spontaneous labor. So you would like to induce her after discussing some pros and cons. Okay. So now any one of the panelists, now you have this lady who has undergone a previous cesarean section 5 years ago for a breech presentation, and it is her wish to deliver vaginally this time. Okay, so and it's already 40 weeks, she's not gone into spontaneous labor. So any of the esteemed panelists would like to discuss induction of labor with this lady, or if you're going to induce her, what are you going to tell her?
Hello. We can discuss the patient.
You can just sit
Previously,
down.
she had cesarean section.
Please sit down.
Previously, she had cesarean section, but now the interval is 5 years. This is good interval. And before induction of labor, we should tell about each and every aspect about the induction of labor. That what are the process, how we proceed for the induction of labor, what are the methods, and what is failure rate, what are the complications, and whether there may be vaginal delivery or it may convert into cesarean section. So first of all, after telling each and everything about the process, its method, its failure, and after taking the written consent, we can go for the induction of the labor.
So, basically, you know, we need to discuss the pros
Yeah,
and cons.
discuss, informed
Otherwise, the
consent.
patient can say
Yeah.
कि madam आप तो कह रही थी कि हो जाएगा, but मेरा तो fail कर गया.
Yeah.
Or you know, if any complication arises as a result of induction of labor.
Yeah, we should tell about the failed induction or what could other we can do. All these we should do after taking written consent.
Yes.
And then we can proceed.
Any one of the panelists wants to add something to this?
Yeah,
I mean, naturally, you know, I mean, if someone tells the patient, oh, like you can't tell her there's a risk of uterine rupture and this, that, otherwise, you know, she'll never go for an induction of labor. So, I mean, gently, you know, we have to tell these complications that we have to closely monitor her during labor. There is a small risk, but we are going to be quite vigilant. So, anything else you want to add about this?
Yes,
I mean, she's a previous cesarean section. You need to tell her, or you know, we'll move on saying that, you know, so what are the methods that you would use in this lady?
First of all, I want to add
Yes.
that before I have to take informed consent from her. For,
We have taken, your colleague, I mean, your co-panelist has
after
taken.
taking the informed consent, I have to do the examination of the maternal pelvis, whether it is adequate or not, and whether there is any cephalopelvic disproportion before attempting for any method of induction of labor. So I have to get an ultrasound done before it to know about the fetal weight and what is the amount of liquor, and to examine the patient perfectly, that the head is in position or head is quite floating above. And after looking at the Bishop score and all the things, then I will decide upon what method to choose.
Okay. So Dr. Tabassum has just mentioned that, you know, you would just like to ensure that it's cephalic and the head is not too high and do an ultrasound scan. I mean, ensure everything is fine for the woman, and after that you go ahead with the induction. Now, so you have examined the patient, head is engaged, and on vaginal examination, Bishop score is less than 6. CTG is normal, reactive. So now what? Like, this is a very quickly, because, you know, we
endocarditis and thrombosis should be given to
Yes,
the
definitely.
while they're sitting. Switch on the mic, switch on the mic.
There are chances of infection here.
That dinoproston gel will cause coronary vasospasm, and that's why dinoproston gel is avoided in a case of heart disease for induction.
If we want to induce, generally dinoproston gel is
Madam,
the preferred method.
this is not
PGE1, I mean to say. Ma'am, that's what guidelines say.
PGE1 is bisoprostol.
No. Sorry, PGE2. I am talking about gel.
Madam, dinoproston gel is avoided in case of heart disease. That causes coronary vasospasm, and it is not advised
It is a
in
vasodilator,
pregnancy
ma'am.
with heart disease.
Okay, so that may be a matter of controversy here, but it is not over there in guidelines. So E2 is the preferred method.
And syntocinon in low dose can be given, up to 6 to 10 millionunit
But
per
as you
minute.
cannot give a very prolonged dose of oxytocin in these patients. First I said if the Bishop is less than 6, then you should
less than
first go
6.
for the ripening followed by augmentation. If it is more than 6, then okay, you can straight away go for oxytocin stimulation. Other things, IV fluid
No,
is
in
to be
heart
restricted.
disease, usually we avoid IV fluids.
Yes,
and
yes,
syntocinon
that
is given
is
through
what.
IV fluids.
That is
so,
how,
Yeah,
that is
so
how.
we must avoid IV fluids.
And one very important component is the adequate pain relief. That is very
adequate
important
pain
in
relief.
cases
Ma'am,
of heart disease.
Now, with respect to the time,
Yeah.
can we?
So, thank you so much to all the panelists. I think you have been wonderful. So I think there was no cause for anxiety in this panel. Already, we have such I mean, you are already doing a lot of obstetrics.
All of us are thankful to you, Pragya and Vinu, and to the expert and to our audience. Thank you.
And thank you very much to our expert.
I also
Dr.
thank you, Dr. Pragya and Madam Vinu, for their such a nice session on induction of labor, which we are doing less, and which we should do more.
Okay. So
Can
thank
we have
you
a
so
picture
much.
with the panelist, moderator and the expert? Can I request Dr. Abarani Sinha ma'am, Dr. Vinita Singh to immediately, and Dr. Supriya Jaiswal ma'am to please join us, as we would like to give them a token of appreciation and the certificate of appreciation as well. Dr. Pragya Mishra Chaudhary, Dr. Rashmi Prasad, Dr. Rashmi Prasad, Dr. Rashmi Prasad, Dr. Sharda, Dr. Asha Dolani, Dr. Sudvita, Dr. Sudvita, Dr. Sumiti Sinha, Dr. Tabassum Ahmed, Dr. Amita, and Dr. Madhu Singh. हाँ, बट आप ऐसे ही फोटो सबको अपना अपना मिल गया है, लेकिन एक फोटो के लिए I'll just check. Can I request? Yes. Immediately we are getting started with the panel discussion. And can I request the moderators for the panel discussion to please join us on the stage? Can I request our moderator Dr. Vinita Singh to please join us, along with Dr. Meena Sawant, our experts Dr. Girija Wagh and Dr. Nibha Mohan. Our panelists, Dr. Kajal Sinha, Dr. Pooja Sinha, Dr. Pooja Kumari, Dr. Sangeeta Kumari, Dr. Nutan, Dr. Alpana, Dr. Rajni Priyanka, Dr. Sadhya Parveen, Dr. Kamna Datta Bakshi. Dr. Girija Wagh has a flight to catch. So she's going to be taking the next 30 minutes, and we would like her to be a part of this panel. So kindly requesting all the other panelists to please take the seats. Thank you. Dr. Pragya Mishra ma'am, आइए ना please. I kindly request to not occupy the stage, as we would like to have the next panelist. Dr. Girija Wagh ma'am, can I hold your hand and pull you onto the stage? नहीं नहीं जल्दी Dr. Nibha Mohan ma'am, आपको भी जाना है, चलो please. How can we start the panel without you?
Good evening, everyone. Let's not waste any more time, because we'll be talking about preterm labor. So let me introduce our panelists to you. We have Dr. Kajal Sinha. Can you please raise your hand, Dr. Kajal? Okay. We have Dr. Pooja Sinha from Muzaffarpur. Dr. Pooja is here. Thank you very much. We need a chair for Dr. Pooja. Dr. Pooja Kumari. Hi. Then we have Dr. Sangeeta Kumari from Sivan. We cannot forget you, your catwalk yesterday. Dr. Nutan. Thank you. Dr. Alpana. Welcome. Dr. Rajni Priyanka. Dr. Rajni is not here. Dr. Sadhya Parveen. Hello. Then Dr. Kamna Datta Bakshi. Dr. Kamna. Hello. So, except for Dr. Rajni Priyanka, we have all our panelists here. And of course, we have two very important experts. Dr. Girija Wagh, she's come all the way from Pune. We all know her, a president-elect. And Dr. Nibha Mohan, our treasurer. Welcome to both our experts.
Very good evening to the August gathering. So today we are having, and this is the last session. So today we are going to discuss on preterm labor. And I think in present scenario, the incidence of preterm labor is increasing, because all the pregnant women, they are mostly elderly women, working hard, moving day and night and working day and night with all so many risk factors associated, and also because of multiple pregnancies because of IVF pregnancies. And that increases the burden of neonatal mortality and morbidity. So let us talk with the panelists how to prevent and how to treat preterm birth. So, regarding a little bit introduction, we all know that preterm is commonly defined as gestational age less than 37 completed weeks. If she goes in labor before 37 weeks, that is preterm labor. And subcategories are very early, moderate, and late preterm labor. And also we say when there is uterine contractions but there is no cervical changes, that is threatened preterm labor. And if there is little bit changes, we say diagnosed. And if there is cervical effacement more than 80% with 3 to 4 centimeter dilatation, it means the preterm labor is established. Coming to the burden, largest number of preterm birth is in India, and that is 3.5 million per year. So now we can see how much burden is in Indian scenario. Now here we can see that the preterm labor burden is very early, 28 weeks. We can see here 28 weeks early, moderate and late. So how much burden is there in current scenario? Now these are the various major causes of preterm birth, and I think infection is very important. So we have to rule out infection. If there is infection, that will lead to preterm birth along with so many etiological factors. So coming to the case scenario 1, a lady of 30-year-old woman attends antenatal OPD with history of 7 weeks amenorrhea. She delivered her first baby 4 years back at 29 weeks of gestation, and the baby weight was 1.3 kg after having abrupt onset of labor pain. The baby is having delayed milestone, and she is really concerned and anxious for her current pregnancy outcome and wish to do everything for a best pregnancy outcome. So I would like to ask Sangeeta, how will you proceed with this case?
Ma'am,
what history you will, you know?
I will ask about the previous history, whether she has, she has any procedure done like conization or anything, or cervical cerclage was done for her, or she has developed any preeclampsia or hypertension during pregnancy in last year and in last pregnancy, and whether she has started leaking first or labor pain only, and she delivered in how fast she delivered, and was she admitted for, has she consulted to some doctors, or whether aneuploidy, since one of the baby is having delayed milestone, so whether any aneuploidy screening was done, NT scan or NB scan, along with that any uterine PI of in last pregnancy was done or not, and whether she is having any substance abuse or like cigarette smoking or anything.
So, okay, so Dr. Pooja, would you like to add something in this, what Sangeeta has spoken?
Yes, ma'am. We will assess her age, if she is teenage pregnancy or elderly, or her socioeconomic status, education status, and pre-pregnancy weight and other pre-pregnancy conditions. And we would assess for her urinary tract infection or genital tract infection. Screening should be done, and any history of vaginal bleeding or leaking or not, or history of any strenuous work.
Okay, so anything else, would you like to add something more?
For investigation, I would like to do first an ultrasound for the viability and gestation dating of the pregnancy, and then investigation to rule out infection, that is urinary tract infection or vaginal infection, bacterial vaginosis, and if she is having history of hypertension, then APLA profile should be done.
Okay. So, Dr. Nutan is here. So, would you like to tell me, because she is giving a history of preterm birth, previous preterm birth, how much risk factor, how much more chances she is having to have preterm birth in these conditions?
Usually after first So ma'am, usually if she has a history of previous preterm birth, there is 17% risk, 17 to 18% risk of again having a preterm birth. And if there is because as per this patient, she is second gravida. So for this pregnancy, there is an increased risk of around 17 to 18% that she might have. So accordingly, we have to monitor her, and we have to take proper history, and we have to screen her accordingly.
So here we can see that if she had no preterm, there is 4.4% chances of having preterm birth. But if there is history of preterm, what you have said already, that is right, that is 17.2%. If there is no preterm, and that is 2.6% only. But if there is preterm and again preterm, but two preterm, then there is 28.4%. So it increases after, one preterm is 17, if two preterm is 28.2%. So what investigation will you do? I think Dr. Sadia Praveen is there. जी, that is very, yes madam, उन्होंने कही है madam, smoking is important.
Right now the patient is at 7 weeks of gestation, so we'll go with the routine investigations like the routine CBC, urine and ultrasonography. And for as she has a history of previous preterm pregnancy, so we must be more focused towards that, so that we can detect it earlier. So we will go for screening for the infections like bacterial vaginosis and asymptomatic bacteria. These are the causes for preterm labor. And we can counsel her that further when the patient comes for the dual marker from 11 to 14 weeks, at that time we can take this opportunity to go for a cervical length measurement. Ideally we should do at 16 to 24 weeks, but at that time also we can measure the cervical length, so we can get an idea of cervical length, whether she will go for preterm labor or not. And we will counsel her regarding all the, she has to go for close follow-up, and all the investigation which we have advised, she should undergo all that.
Yeah, please.
Ma'am, first of all baseline investigation which we do in all patients, and routine examination of urine for sugar, protein, any pus cell, to rule out any asymptomatic bacteriuria may be the cause, and TSH and OGTT by DIPSY criteria.
She has covered that. If you have anything new to add, please add, because we'll be just stuck in these questions.
Okay.
Anything else? So we need to do, the new thing that you added was a cervical length, but what is the time? She's still only 7 weeks. In infections, bacterial vaginosis can be important for her because that's a known cause unless there is some florid infection. And cervical length measurement, it is like you said 18 to 20, but there is a prior history, we can start earlier on also. What about the progesterone therapy? Is there any role of progesterones in this patient?
Yes ma'am, we can start.
Yeah.
Ma'am, because she already has a history of a preterm delivery in the earlier pregnancy, we can put her on vaginal progesterones right from early pregnancy, and that can we can take it up till 34 weeks depending upon her cervical length. So progesterone, intravaginal progesterone would be an ideal treatment for her.
Ma'am, progesterone is recommended after 16 weeks of pregnancy.
Okay.
But if there is a history of preterm delivery in previous births, then we can add from first trimester also, because it will help in preventing preterm labor. So it is not like that we should start it from 16 weeks. We can start it from first trimester also if there is a history of preterm birth in previous deliveries.
In this scenario, we can start start from early.
Yes, we
but
can
if there
start.
is any shortening of the length, cervical
Yeah.
length, in that case we can start from. If we do, at 16 to 24 weeks, we go for, if there is shortening of the cervix, cervical length is 2.5 or doesn't that, then we can start from 16 weeks.
16
if in this
weeks.
case, we can start early also.
From early,
and I
yes.
think progesterone gel is more important rather than moving for oral progesterone. I think what is your suggestion?
Our experts are
Yeah,
here.
experts. ma'am.
Thank you so much for that wonderful discussion and the case scenario, because this is something which is a very common case scenario that I have. You've asked me a question about progesterone, but I would like to add something else also. Whenever a woman has come with such a previous bad obstetric history, the first confirmation scan, you can also speak to the radiologist if he's doing or you are doing. Look for any septum or any cavity disorder or maybe a unicornuate uterus, because that must have been missed priorly. Now this doesn't actually influence the outcome, but it may contribute. And then in that case, and in otherwise also, progesterone can be given prophylactically in this patient, but remember that the efficacy of progesterone in bringing about myometrial, all those 4 actions which we speak about progesterone, are usually attributed to the natural occurring progesterone from the woman's body. External progesterone, the efficacy would be only about 30%. Because there are possibly so many other confounding factors. Like I was listening to the panelists, but they never mentioned about anemia. And anemia is something very important because oxygen carrying capacity is reduced, CBC, but look at, many times we accept even 10 as normal, so it should always be 12 gram%. Women should be replete with proper serum ferritin because that weakens the myofibrils. There's an inflammatory process which can cause preterm births, that's one. The second thing about progesterone is when to start progesterone. The question has been answered by most of our infertility specialist friends when they start already from the luteal phase support. Whenever such a patient comes, the current AI in NICE 2022 guidelines, I'll share the PDF with here on our group also. They have mentioned that you are justifiable in starting if there is threatened abortion or a history of a previous loss or a miscarriage from 8 weeks onwards once you confirm the pregnancy, and continue but not till 34 weeks. When to discontinue was decided based on the wisdom of the panelists because there is no data to protect this. So then there is one study, and that PROMISE or the PRISM study, which says that we can take it till 26 weeks of gestation, and beyond that it will not have any efficacy. So this is about progesterone. Now talking about 3 types of progesterones that we have, the other one is dydrogesterone, and currently it has been placed also for prevention of preterm labor, but there are no studies to talk about its efficacy in preterm labor. And thirdly is the 17-OHPC, which has now been withdrawn from the market outside because of the fact that 17-OHPC is related with occurrence of malignancies. But friends, I must tell you that that study says when it has been used during the period of organogenesis. But still that injection which Makina or something is called outside has been withdrawn. So this is the current status. So we shouldn't take sides of ye acha hai, kya wo acha hai. And then sometimes we are giving progesterone, pushing it into the woman. We are not realizing that probably we feel that we are doing everything nice. But it may not be always complete, and there are so many other things like thyroid antibodies can be responsible, anemia, genitourinary infection she mentioned. And then the cervical scanning which you said, ideally whenever there is a risk patient, do it at 16 weeks of gestation itself. But I have seen in the genuine cervical insufficiency that these women again start dilating even at 19 weeks of gestation. But then that gives you a leeway, that gives you a rationale so that these things can be properly used. And anyways, out of all so many of your patients, 1 or 2 cases are like this who definitely mandate that you give them proper attention. And before, since I have to leave, I'm sorry, but I'm going to add some more else. Start a good calcium supplementation to them early on because calcium is known to cause myometrial quiescence, reduce preterm births. You can consider giving her low dose aspirin, that has also been contributed, but there is again a skewing is there because it may be preventing pre-eclampsia and anti-inflammatory processes. And the third one is giving DHA. Nowadays, lot of neonatologists are promoting that you give DHA to these mothers because if they are going to go into preterm births, then this will help in better neurological outcomes of the babies. So with this, can I take your leave?
Thank you
so
very much, Dr. Girja Wag, for your expert comment, and really it was very informative about every one of us. So thank you for coming and gracing, this function, this our conference. Thank you very much.
Thank you so much.
Thank you, Dr. Girja ma'am. Thank you. And for starting the progesterone, sometimes we start progesterone for recurrent pregnancy loss or even after first miscarriage in the luteal phase itself. And if the patient gets pregnant, we can continue with that progesterone. So it started before pregnancy confirmed also.
Now, we started pregnancy and everything was going on well, but her pregnancy was progressing well up to 22 weeks, and an anomaly scan also reported to no gross anomaly was seen, but mentioned cervical length, and that was 24 mm confirmed by TVS. She was asymptomatic totally, though. She is very concerned that this pregnancy too will end prematurely. So now what to do? How will you proceed, Dr. Alpna?
As the cervical length is 24 millimeter, it is just borderline for the more chances of low cervical length, less than 24 mm. As the cervical length decreases from 24 millimeter to 5 millimeter, the rate of preterm delivery increases much. And as the patient has previous history of preterm labor and she is also much more anxious, two types of things we can do. Either surgical cerclage or medical cerclage, already discussed very well, as the we can go with vaginal progesterone, or cerclage operation can be done between 16 to 24 weeks, and all the parameters of baby and anomaly scan all are well right. We can wait and assure and other, if any other risk factor is associated, we
So we have already ruled out many other risk factors,
Yes.
and what we got apart from the previous preterm delivery, a short cervix, and you mentioned that we have now two ways to go, either progesterone or
cerclage.
cerclage. One of the two we can do.
And first we confirm, say all the risk factor of medical and surgical process, and take her consent, and then we go for.
Okay, you started all that, but there is even with progesterone, even with cerclage, there is no 100% guarantee that she will not go. Now you've done whatever you had to do, and now you're sending her home, and she wants to know how I will recognize, doctor, if I am going. What are the predictive signs and predictive tests? What you going to tell this patient?
If we tell her about the hyperactivity of her uterus, if more contractions and painful contractions occurs, she will be aware of all these things. Her fetal movements count should be done for her fetal well-being, and we do ultrasound.
Any role of fetal fibronectin?
Yes. There, if the level of fetal fibronectin is less than 50 microgram, it is less chances of less chances of preterm birth, and if it is more than 50 microgram, then the more chances of preterm there. If it is possible to, we can do this screening test.
So I think we've covered this part of the management, progesterones and all that. And you have beautifully covered regarding the role of this thing. And yes, apart from, even if she's had a previous preterm up till 34 weeks, late preterm also, then also it helps.
Yes.
So the conclusion there was, this is meta-analysis regarding the update on short cervix. It concluded in the systematic review and meta-analysis reaffirms that vaginal progesterone reduces the risk of preterm delivery and neonatal morbidity and mortality in women with a singleton gestation and a mid-trimester cervical length of less than 25 mm without any deleterious effect on the neurodevelopmental outcome. So again, yes ma'am, yes ma'am.
Cervical encerclage.
No.
Cervical assessment. 16 to 24 weeks, madam. It's ideal time is
16 to 24 weeks. Not routinely, नहीं कहते कि routinely करना है, but usually हम लोग कह रहे हैं कि जब anomaly scan कराना उस वक्त cervical length जो है assess कर लेना है. That should be in between 16 to 24 weeks.
Ultrasound.
TBS कराता.
मैडम 14 वीक्स तक हाँ शुरू कर देना, जिसका हिस्ट्री है स्पेशली मिड ट्रिमेस्टर अबॉर्शन का, वी मस्ट स्टार्ट बाय 12 to 14 वीक्स. यस मैम, यस मैम. मैडम भी पकड़ लेती हैं.
मैडम 20 वीक्स वो जो लेवल 2 कराते हैं फॉर कॉन्जेनाइटल एनोमली, तो हाँ तो वो रूटीन है, बट मैडम इज आस्किंग क्लिनिकली
रूटीन है मैडम, लेकिन अगर प्रीवियस हिस्ट्री है उस वक्त हम लोग पहले से ही शुरू कर देते हैं.
So the third part of this same patient is at 32 weeks. You gave her, but at 32 weeks she attends with regular uterine painful contractions. She comes to you again that she has now regular uterine contractions. So now what are you going to do in examination investigations? At 32 weeks she has come to you. हाँ, हम नाम देखना भूल जाते हैं.
Ma'am, we'll admit her and we'll first do a PV examination. After CBC, we'll find out if she's having any infection. And a CBC, a speculum examination, and we'll see how much dilatation she has. If she's actually dilating, then we will have to give antenatal corticosteroids to at least delay it for 24 to 48 hours. And that can be helped by tocolysis. That we can do either with nifedipine or with magnesium sulfate.
Frankly, do you really use magnesium sulfate?
Ma'am, where I'm working right now in Faridabad, we have started using magnesium sulfate there.
For this thing?
For this, ma'am, yes.
Okay.
We have started using, we were using nifedipine, ma'am, but that was causing, at least psychologically, we were feeling the patient going into hypertension. So we started using magnesium sulfate.
She's saying the patient is already in labor, 32 weeks.
To at least buy 24 to 48 hours for her.
She for as a tocolysis.
As a tocolysis, ma'am.
Anything else you can use instead of nifedipine? Suppose nifedipine is not there. Any other tocolytics?
Atosiban is available, but it's very expensive. So
it's very expensive, but
it's very
can
expensive.
Use
it's very expensive.
Anybody using isoxaprine?
Yes, ma'am, we all are, but we all are using, but it's not very effective.
Has recommended it.
We all are using, ma'am, but we're not talking about it because they say it doesn't have any role, but we all are using Dividilon.
Dividilon. No, at least not the Western literature. Our own Foxy is recommended.
We are using Dividilon.
So which steroid will you prefer? Dexamethasone or betamethasone?
Ma'am, if I have admitted her, I'd prefer to give her dexamethasone. I want to give it to her every 12 hourly. If an outpatient, instead of asking her to come after 12 hours to the hospital, but if because now she's an inpatient, I like to give her dexamethasone 6 milligram every 12 hourly for 4 doses.
So what is the added, why you are giving dexamethasone, why not betamethasone? Any added advantage or what is the reason behind this?
Maybe it's short acting, maybe it is short acting, ma'am, maybe because it is short acting, and if she goes into labor, maybe that will help. It's a compared to betamethasone, maybe it's a shorter acting, and it have a
it is
very difficult because it comes in 4 ml vial or 8.
And 4 doses we have to give, and betamethasone we are giving only 2.
So
That is an even.
instructing the staff that you have to give only 1.5 ample, 1.5 ml.
I know if the PGs are there in exam, they have to say dexamethasone because it's much more cheaper. It's, advocated by the WHO. And also, the betamethasone, not only is it more expensive, many times it may not be available. And also it is the chemical compound that is available here, it's found that it doesn't work as long as what is normally it would do. So the salt here is a little different from what is advocated generally where the studies are available. So that is another thing. So
Ma'am, if we have to treat the patient on daily basis, in OPD basis, it is difficult to give.
Yeah, I know you have to use 1.5 vial of that.
No. For 2 days for 40.
But then
6 milligram.
If that is the dose, we have to follow the dose. We have to follow the dose for the best
Advise the
action.
patient and she'll take if she is not admitted.
We don't have to go by our convenience and patient's convenience. We have to go what is recommended.
So would you like to go for high vaginal swab to rule out infection?
Yes, ma'am. Definitely. Per speculum examination is must, and PV, no to PV, because in per speculum examination we can see the status of the cervix, whether it is patulous, 1 finger, 2 finger, it is seen only. We need not to introduce our finger to do PV. We may high vaginal swab culture or cervical culture is taken for bacterial vaginosis and group B streptococci. For both culture and sensitivity should be taken.
So I think you all have beautifully covered what is the advantage basically of antenatal steroids? Why are we all giving?
To reduce the chances of respiratory RDS, respiratory distress syndrome, intraventricular hemorrhage, neonatal morbidity and mortality.
Okay, so that we all know, and I think that's a routine practice. Even patients coming from periphery, they've all received a dose of this thing. And do you repeat it?
Yes, we can repeat. We can repeat after 7 days. If patient again goes into preterm labor after this quiescent stage of them, we can repeat it. If there is chances of imminent delivery and patient is again in the preterm weeks of gestation.
Which preterm? Preterm is a long duration.
Before 34 weeks.
So
before
rescue,
34
you
weeks.
agree with the rescue dose that she has said?
Yes, sir. We can repeat. Maximum 2 cycles of corticosteroid doses can be repeated, but not more than that can be repeated, because there is chances of neurological complications of steroid, and also there is.
No, in the morning also we had a beautiful, lecture on this. So if you are giving a rescue dose, at least for 14 days, has to be a duration of 14 days. And before she is 34 weeks, if she has already crossed 34 weeks, no need
No
to
need
give
of
any
giving those
rescue dose.
corticosteroid.
Yeah.
So you said that no need of giving a steroid after 34 weeks. But is there any role of steroid if she comes at 35 week of gestation? Would you give a steroid or not?
First cycle of doses can be given, but not that repeat cycle.
Yes. So first dose can be
First
given,
dose can
and
be
we are
given.
giving. We are
Yes,
giving.
yes.
But before cesarean, before a patient come, if we plan to do cesarean, if we give 1 dose of steroid, it decreases TTN in newborn.
Okay, that is another thing, and that is if we are doing an early or a late preterm or just before 38 weeks or so. So we are not touching on that. We are still in the preterm labor. In preterm, we do give. There is no controversy. So what you are saying is different. That is valid. Another situation.
So I think we have done with this tocolytics. So what are the contraindications? In which case you will not give tocolytics? It's very easy.
10 minute बाकी है, जल्दी कर दीजिए. So coming to the magnesium sulfate. Madam, you're giving a lot of magnesium sulfate at your place. So is it for the neuroprotection or is it for the tocolysis?
Ma'am, both, ma'am. Both. It does help in both.
Okay.
Nowadays, ma'am, we have that 100 ml saline magnesium sulfate. Earlier we used to, earlier we had to calculate and tell the sister to titrate it. Now because we have the 100 ml available, so it's easy. It goes start within 25 to 30 minutes, and then we give the next drip 1 gram per hour till at least 24 hours.
So that is for the neuroprotection.
Yes, ma'am.
So when do you start and how early can you give until what is gestation?
Ma'am, if she delivers within 24 hours, then of course she's delivered. If she doesn't deliver, it's 24 hours has elapsed, we stop the Maxelf.
So from the audience who all are using Maxel for neuroprotection in preterm labor, anybody using? पीछे वाले अमिता Dr. Sangam, you're using magnesium sulfate, no? So raise your hand. So we all are using. I think this is something that has come into practice. Before 33 weeks, 34 weeks, if we give one 24-hour dose, like as in, even a single dose helps. 4 hours, yeah. हाँ. मैडम जो हम लोग प्रिचार्ड और
IV start
loading 4 gram.
चलिए चलो जल्दी करो.
There are 2 regimes, ma'am. Pichard IM. That is for Pichard IM.
Madam, 4 gram IV dissolved in 15 ml, that's given slowly for 5 to 10 minutes, and 1 gram hourly for 24 hours or till delivery, whichever is earlier.
And that IV 100 ml is now also available in Patna, like Madam was saying, that's also quite convenient.
Yes.
Dr. Aru, acha, you have just come, I thought you want to make some comment. Yes, please. So that is, if we are electively terminating it, well, yes, very good. But if she is already going into labor, it is not in our control. But even if we get 4 to 6 hours window, it is good. It will do some benefit to the baby. That is for steroid. We'll
That is
discuss
for
later.
steroid.
Don't mix up the two.
Don't mix up both the things. That is for steroid.
So now everything was fine, going on well. She went home. Again, she came 9 days after, and she said that she is having painful uterine contractions and blood-stained discharge. Speculum or distal examination revealed cervix 3 to 4 centimeter and 90% effaced. It means that she has, established preterm labor, and she is having breech presentation revealed on ultrasound, and birth weight is 1.8 kg. Now, what will you do, Dr. Sadia?
As we can see that she is already in established labor, so we would prepare our labor room and OTs for delivery, and we will see that the proper neonatal care, the neonatologist is there or not, or bed for ventilator is there or not, and then we can go for speculum examination to take the swabs for this HVS, high vaginal swab for culture sensitivity. And as we can see that the baby is in breech presentation, so we should the preterm breech, we should preferably go for cesarean section, and we should start antibiotics if there is a chance of we get group B streptococcal infection is there, then we can prophylactically start antibiotics, and as per for preterm it's not recommended to start prophylactic antibiotics for that.
I will just like to make a comment here, because this question was asked in the previous thing also. Even if those who are not, because when we do send our cultures, even if though it is vulvovaginal or high vaginal, They're not testing for GBS. And the recommendation says if she goes into preterm labor, we assume that she should be covered for a GBS. So a broad spectrum antibiotic should be given for
Erythromycin.
preterm labors, not the routine, but for preterm to cover for GBS also.
So coming to the case scenario 2, because we are running short of time, a 30-year-old gravida 2, para 1 at 30 weeks gestation, presents to the obstetric emergency in the morning with suspected leakage of fluid per vagina since overnight. She has a history of systematic lupus erythematosus and is maintained on prednisolone 20 mg daily. In addition, she reports her current pregnancy is having experienced scanty vaginal bleeding throughout her first trimester. Currently, fetal well-being is reassuring and the patient has no contractions noted on CTG. Her abdomen is soft and she is afebrile. So now what is the catch point risk factors in this case and what will you do, Dr. Pooja?
Ma'am, risk factor for this case is SLE and chronic use of steroid and also first trimester recurrent history of spotting and bleeding.
Any other history would you like to take in this case? And
Ma'am, we will, is the primi or multi? Primi gram.
Because she is a
So
case
we will ask about the previous baby, whether the baby has developed lupus, neonatal lupus or not, or congenital heart block in previous neonate or baby.
So as she has said, that's little bit leaking.
Yes.
So how will you confirm whether it's a case of
it may be so
premature rupture of membrane or it's differential? What is the differential diagnosis in this case? How
So-
will you confirm? How will you confirm the diagnosis of premature preterm labor?
Ma'am,
Premature rupture of membrane.
actually the pH of liquor is alkaline. So nitrogen test is bedside test. Can
Would
be
you like
done.
to confirm
So
by
blue test.
per speculum examination?
Yeah, we will
I
do.
think that-
We
yeah.
will do per speculum examination. Whether we will search for any uterine tenderness or maternal and fetal well-being. We will decide, and then we will do.
Question is, how do you decide whether it is PPROM or you?
So by per speculum examination only.
What do you see?
Yes.
Like, what do you see?
I see that leaking from the cervix, and cervix is patulous, soft, and whether it is congested or whether it is so or something high.
So what is the yeah, it's confirmed. Now suppose it's say no, it's not confirmed, and there is some leaking risk. You are saying that suddenly. What is the differential diagnosis? What other things
what
will
else
come in
can
your mind? Dr. Nibhaman, would you like to comment? on this?
Urinary incontinence may be the just because of UTI.
Any other discharge, like you are seeing watery discharge coming from internal os, if you are sure, if you are 100% sure it's coming out from os, it's sure that it's PPRM. But if you are just seeing the liquid, it can be urine, it can be other discharge.
Even we will go for ultrasound. An ultrasound, you will see that there is scanty liquor, less liquor. Then you will confirm yes, it may be a case of premature rupture of membrane. And any other test for confirmation, doctor? Yeah.
Insulin growth factor binding protein and PAMG, that is placental alpha microglobulin 1, it is present in the cervical fluid, then we can assess that this is a case of PPROM. Generally we don't do, but these tests can also be done.
So how it is, those are available as a liner which or you take and you do, you
Yes.
get the color check. But no longer are we doing these nitrazine blue. Now they have gone out. Don't quote them.
Okay.
We go for PAMG and this thing, what is it? But most do not forget to do the PS. In 80 to 90% your diagnosis will be confirmed.
So it's confirmed she is a case of premature rupture of membrane and she has gone in labor, preterm labor. So what are the complications you will expect, maternal and neonatal complications in this case? Yeah.
The complications are like there can be IUD or chorioamnionitis,
increased risk for intraventricular hemorrhage or fetal lung hypoplasia, increased chance of respiratory distress syndrome, also the increased chance for cord prolapse, cord compression, like this.
Yes, you can go ahead. Meena, let us complete.
And of course, for the mother, you already were pointing it out that we have to look for the PPROM. Sometimes even the cord may prolapse or they may be abruptio.
Yes,
So those things we have to take into consideration. This question I think partly has been discussed in the previous panel. Is there any role of conservative management, expectant management? Do you like to deliver or wait for some time?
No, we can wait, madam. There is no maternal stress and no fetal distress is there, no contractions are there, so we can wait for the expectant management.
Yeah, so we have to monitor both the mother and the baby, and if everything is fine, then we can
Discharge her and call her 2 weekly for the
yeah, some
follow-up-
people, if
follow-up
it is a long
scans and
time, some
examinations.
yeah, some patients like to go, but still you have to keep calling them
Flare
again.
up of the SLE also we have to look, madam.
So would you give corticosteroids? All
Yeah.
of you?
Yes, madam.
Would you like to give magnesium sulfate if you're expecting her delivery in next couple of days?
Yes.
I think so that the message has gone. What about antibiotics? In the non-ruptured this thing, we are not giving routine antibiotics. What about PPROM?
We can give, we have to give.
We have to give, yes, thank you. And what about, so I think we have written, next fellow. So what is the appropriate time to deliver these babies?
And we can wait till 37 weeks unless and until no complications are there.
Now the guidelines say we can, if monitoring and everything is going fine, you can go right up to 37
7 weeks.
or any other time if the things are not going or
In between we can
yeah.
do the...
Now we have not taken the case of late preterm, time did not allow, does not allow, but we want to prevent the complications of late preterm. That is one important thing where late preterm itself, because after 34 weeks we think nahi bachcha to theek hai, bach jata hai, but that should not be our in this thing.
Okay, so but proper monitoring is very necessary. We will go for CTG and ultrasound routinely, and we will continue till 37 weeks, and then we will terminate. So
to the SLE patients, we have to look for the flare up of the things,
of
madam, like anti-double standard DNA antibodies, complement like CH50, C3, C4. We have to look into them, and like the APLA antibodies also.
So thank you very much for very interactive sessions with all esteemed panelists, and I think each and every most of the point has been we have dealt with, and thank you very much, and thank you expert Dr. Nibha Mohan.
Can I request the panelists, the experts and the moderators to please join in for a photograph, and can I request Dr. Abha Rani Sinha to please do the honors of giving the certificate of appreciation to all our panelists, experts and the moderators as well. Dr. Pooja Sinha. Next is Dr. Kajal Sinha. Dr. Pooja Kumari. Dr. Sangeeta Kumari. Dr. Rajni Priyanka. Dr. Sadia Parveen. I know this lady. Dr. Vinita Singh.
Yes, this is the big one.
Dr. Kamna Datta Bakshi. Dr. Alpana. And Dr. Nutan. Thank you so much. And with that, I request all to please pose. Anyone you just... Look into the camera, 3, 2, 1. It's time for the valedictory function, the most important part for me. because I love that it's the time, because conference समय पे हो गया इसका मतलब. Ideally 5 मिनट डिले उतना डिस्काउंट चलता है. With the valedictory function actually is at 5, but 15 minutes. Dr. Lakshmi Jha, if you could come forward. Dr. Abha Rani Sinha would like to give you a warm hug. नहीं अभी तो देना पड़ेगा. देखो जल्दी आ जाएंगे ना वो फिर. अच्छा इधर ही, हाँ हाँ इधर ही. So you can see now Dr. Abha Rani Sinha hugging Dr. Vinita Singh and Dr. Dr. Alka as well. Dr. Meena, they both are wearing similar color sarees also. देखो कितना प्यार गहरा है. जब दोनों साथ में आते मर्ज हो जाते हैं, पता ही नहीं चल रहा है दो अलग लोग हैं. सूट और साड़ी मर्ज हो रही है. हरी ये माइक बंद हो रहा है, बैटरी चेंज कर. हाँ? अरे और कुछ समझ में तो आता नहीं है. All right, request all the pharma friends to please join us. It's Can I request all to please settle down so we can get started with the valedictory function? Start कर दें.